Shall we start? Yeah. So, very good morning, ladies and gentlemen. I am Dr. Kirti Suta, and on behalf of CMRE, I welcome all of you to 10th International Symposium in Diabetes, being organized by CMRE in association with AASD and DIPSI. And on behalf of the directors of CMRE, Dr. Rajiv Chawla sir and Dr. Shalini Jaggi, we promise you an excellent scientific feast with great deliberations and expertise delivered by our expert speakers, international and national. So to start with the first symposium, I would like to invite Dr. Amitesh to chair the session. Dr. Amitesh is Professor, Department of Medicine, University College of Medical Sciences and GTB Hospital, Delhi. Welcome, Dr. Amitesh, and over to you for the further proceedings.
So I think we have already been waiting too long. Let's start with the session. I invite our next speaker, Makar sir, for his talk on multi-pronged approach to the disease management addressing diabetes at CV risk. Sir, as we all are very well aware, doesn't need much introduction. He is has a foremost in almost all conference and an expert on diabetes and especially in obesity. And he is the director of Dr. Makkar's Diabetes and Obesity Center and president of RSSDI presently. So without much ado, sir, over to you for your talk, please. Thank you.
Thank you, Dr. Amitesh. Good morning, everyone. At the outset, I would like to thank Dr. Chawla, Dr. Shalini and team CMRE for this opportunity and putting me as the opening batsman for this session. So I am going to speak on the multi-pronged approach to disease management addressing diabetes, weight and cardiovascular risk. And just to inform everyone that this is a Novo Nordisk sponsored session. So this is my disclosure slide. In this presentation, I am going to first speak very briefly about the type 2 diabetes burden in India and globally and how to tackle the issue of multi-pronged upstream approach. How to, address it differently as compared to what we have been doing earlier. How does oral semaglutide fit into the management of type 2 diabetes, and then what are the updates in recent guidelines relating to GLP-1 RA or GLP-1 receptor agonist. So let us have, the look at the challenge. So we know there is a huge burden of diabetes globally as well as in India, and we have more than 530 million people in globally living with diabetes and another 464 million people with pre-diabetes. We have the largest population of diabetes people in India with 101 million people, and look at the number of pre-diabetes. We have more people with pre-diabetes as compared to those living with diabetes. Almost 88% people with type 2 diabetes are overweight or obese. In India, almost 75% people are above the target of A1C more than 7%, and more than 70% of people with type 2 diabetes die of heart disease. If you look at population with diabetes in India, almost 2/3 have obesity. I am not talking of overweight, obesity. 9 in 10 with type 2 diabetes have obesity or overweight. 1 in 10 adults have type 2 diabetes, and 4 in 10 adults living in India now have obesity. Now with that background, how should we tackle this epidemic or the burden of diabetes? And we have to look at a multi-pronged approach. Now it is almost 30 years back that people started realizing that type 2 diabetes and obesity are closely linked, and the term diabesity was coined. Up to 85% of people, as I showed you earlier, 80 to 90% of the people with diabetes, type 2 diabetes, are overweight or obese. So, repeatedly I am talking of diabetes. So, just to make it clear, in this presentation, whatever I am talking about diabetes, it relates to type 2 diabetes. It is not type 1 diabetes. And it is estimated now that more than 300 million people with type 2 diabetes have associated obesity. Studies have clearly shown that every unit increase in body mass index leads to a significant increase in the risk of developing diabetes in people who are overweight or obese, and even with people who are normal weight. Now, in this slide, I will not go into the details of pathophysiological mechanisms. The important point to understand is that once there is adiposopathy, that means there is sick fat or there is inflammation in the adipose tissue. It leads to two different sets of reactions, and there is increased turnover of free fatty acids coming from the sick adipose tissue. There is increased turnover of adipocytokines, and there is decrease in the adiponectin levels. And this, through different mechanisms, ultimately leads to mitochondrial dysfunction, which on one side leads to development of insulin resistance, and on the other hand leads to development of beta cell dysfunction. Both contribute to development of hyperglycemia in people with type 2 diabetes. Now, once we make these people lose weight, even as small as 5% weight loss is associated with improvement in blood pressure and dyslipidemia. If somebody is losing up to 10% body weight, we know that there can be it can help in preventing diabetes, preventing NFLD, reduce the risk of PCOD and dyslipidemia. If you go above 10% weight loss, you can lead to remission of diabetes, reduce so many mechanical complications of diabetes, and if you are achieving more than 15%, you are looking at reduction in CV mortality and improvement in the heart failure also. So every weight loss is associated with benefit, whether you are targeting a small weight loss or higher weight loss. And higher the weight loss, better are the benefits. This is data from Diabetes Prevention Program. I'm sure you remember this was a large prevention program for diabetes and showed that lifestyle interventions with modest weight reduction of 7% led to 58% reduction in the risk of diabetes in people who were in the intervention arm. Now this is data from Look Ahead study, again showed that even modest weight loss improves the glycemic parameters, and higher the weight loss, better is the impact. Degrees of A1C and fasting glucose reductions were proportional to the magnitude of weight loss. Now, in people who had lost more than 10% weight, there was significant reduction in the cardiovascular endpoints, whether it was the primary endpoints we were seeing or the secondary endpoints we were seeing. So anything going upwards of 10% weight loss or 15% weight loss has been shown to give you cardiovascular benefits. And so is the data from, this is the data from the direct trial, which was presented at IDF meeting in Abu Dhabi 2017 for the first time. And this was a study conducted in United Kingdom across 45 practices, UK and Scotland. People with obesity and type 2 diabetes were given very low calorie diets for 3 months and followed up for 1 year. And people in the intervention arm who lost, intervention arm had remission of diabetes in 46% of the people. Now, interesting thing is, if you look at this slide, people who lost more than 15% body weight, 86% had remission of diabetes. At the end of 2 years, 70% of them were still having remission of diabetes. Not only that, people who lost more than 10% body weight, almost 60% had remission of diabetes. So significant weight loss is very important for inducing remission of diabetes. Now, weight loss on one hand disrupts the underlying pathophysiology of diabetes and reverses and slows down the disease progression. On the other hand, by promoting glycemic control, it improves the cardiovascular risk factors and also reduces the risk of both macro and microvascular complications. So it is a win-win situation if you focus on weight loss in people with type 2 diabetes who are overweight or obese. So this has led to thoughts about the upstream approach. We have obesity or adiposopathy, which is a key driver for developing a number of diseases associated with obesity. Obesity is possibly the mother of all important diseases of adult life. So if you treat obesity, you actually prevent the development of diabetes and downline hyperglycemia and the complications. So rather than treating hyperglycemia and then treating complications, it is very important to understand that if you intervene here, this place, you will be able to cut down the risk of diabetes and all the downline complications and improve the quality of life. Now let us see how oral semaglutide fits into the management of type 2 diabetes. So we know oral semaglutide is the most potent GLP-1 RA, but it is injectable. Now it has been combined with something called SNAC to give you the oral version of semaglutide. We all know about this, and this is a long half-life which can give you a sustained levels going up to 1 week. Now important thing is most people don't want injectable. So this fits into the bill by providing first oral GLP-1 and gives you significant A1C reduction and good tolerance. 80% of the people have good treatment satisfaction. Initial side effects are usually GI upset, which goes over with time. So this is a slide from all pioneer trials, which was the oral semaglutide development program, where oral semaglutide was tested in multiple settings, whether it is monotherapy with comparators like sitagliptin, liraglutide, empagliflozin, and so on. Across board, it gave you A1C reduction in the range of 1.5%. So significant A1C reduction, and almost 70% of the people were able to achieve target A1C of 7% or less, which is very significant. In addition, there was a significant weight loss going up to 5 kilograms across board, all trials with semaglutide, oral semaglutide, and this was better than all the comparators that you are seeing. And also, if you look at the sustained weight loss at end of 1 year, the pioneer also showed sustained weight loss in people who were treated with oral semaglutide. Another important thing is people with diabetes are on multiple medications. So even add on to background medications, it gave you significant A1C reduction as well as significant weight loss. Now, how does it work? GLP-1 RAs work centrally by improving appetite regulation. So they work on the POMC CART pathway, thereby reducing the appetite or energy intake. And on the other hand, they also inhibit the NYP, agouti-related protein pathway, thereby improving satiety. So they cut down the appetite. And if you look at the weight loss, there is more weight loss from fat loss rather than the lean mass, which is 3 times better. Number of people achieving dual, endpoints, more than 1% A1C and weight loss of 5% was again significantly higher in people treated with oral semaglutide. In addition, there is improvement in cardiovascular risk, decrease HSCRP, improvement in LDL, decrease in systolic blood pressure, and so on. And we have sufficient data now, more than 6,000 patients exposed in trials showing good safety profile, only initial intolerance which happens in about 10 to 15% patients but goes off with time in most of the settings. Important thing is this is to be taken as first thing in the morning orally without taking anything else, with a measured amount of water which is about 100 to 120 ml, and no further intake for next 30 minutes so that its absorption is not disturbed. Dosing is you start with 3 milligrams, go 4 weeks, every 4 weeks you go to 7 and 14, and then follow up patients on 14 milligrams. Now let us see what is the recent updates. There are a couple of papers presented at the ADA meeting and looked at the indirect treatment comparison between the cardioprotective effects of semaglutide versus liraglutide, and this comparison showed that if you look at the 3-point MACE in the indirect treatment comparison trials, results showed that there was a better CV risk reduction with semaglutide as compared to liraglutide. Results show that effect of semaglutide on CV outcomes may be greater than the effect of liraglutide. This is important point which indicates that we should explore this further. Another thing that was interesting was this was a study from Denmark, more than 87,000 patients in Danish population who were given combination of GLP-1 plus SGLT2 inhibitors, and they were compared with other standard two oral agent combination therapy. So the point for comparison was DPP-4 SU or triglitazone combination, And people who were given SGLT2 or GLP-1 combination, they showed reduction in the heart failure, though this did not achieve statistical significance, but significant reduction in the 3-point MACE when there was a combination of GLP-1 and SGLT2 inhibitor given, and very significant reduction in the all-cause mortality, which was seen in these people who were given combination of GLP-1RA and SGLT2 inhibitors. Similarly, there was a paper published on combination therapy impact on the renal outcomes, and again the comparator was the dual combination therapy, which did not include GLP-1RA and SGLT2 inhibitors. And again it showed that there was significant reduction in the end stage renal disease, and there was improvement in the EGFR rate of decline of EGFR in people who were given combination of GLP-1RA and SGLT2 inhibitors. So if you are combining SGLT2 inhibitors and GLP-1RAs, this gives you a very good combination therapy and win-win situation. So if you look at the current guidelines now, we have focus on GLP-1RAs. It is recommended to induce advocate weight loss going up to 15% to improve all metabolic parameters and improve disease status. All patients should be focused on glycemia management, weight management, cardiovascular risk reduction, and cardiorenal protection. It is not one-step therapy now. You have to focus on all 4 components. And for efficient weight loss, you have to use potent agents like GLP-1 receptor agonists. So when you are using these agonists, GLP-1RAs, you can actually achieve good glycemic control and also the weight reduction. So to conclude my presentation, we have very huge burden of diabetes, and of these people with type 2 diabetes, almost 80 to 90% have overweight and obesity. And in this situation, a good GLP-1RA, especially if you have oral GLP-1RA, it fits the bill very well and is an important tool in management of people with type 2 diabetes and obesity. With that, I conclude my presentation. Thank you very much. I just finished on time.
Thank you so much, sir. Just 1 or 2 points I need from you, sir. So compared to the oral versus injectable semaglutide.
Oral versus injectable. Okay.
So apart from the needle aversion, is there any other advantage of oral semaglutide compared to vis-a-vis the subcutaneous one?
Can you repeat? I didn't.
Apart from the needle aversion, are there any other benefits of using an oral?
Actually, your mic is, I think, not. Yeah. Apart from?
Sir, the major point of using an oral compared to the subcutaneous is the needle aversion.
Yes, needle aversion. Yeah, this is the biggest challenge is needle. See, if you had insulin pill, would anybody object to insulin therapy? It is the needle.
Agreed.
Yeah. So big advantage is that you have oral formulation.
So my second part is, sir, in your experience, I just wanted to know, are people more comfortable taking a once a week subcutaneous one rather than a daily oral medication which has got its own bindings compared?
So I have both kinds of experiences. There are people who are very happy with once a week, but there are people who tend to forget once weekly. Okay. So they find it once daily dosing is better because it becomes a routine. But setting a weekly routine is not easy. You have to put a reminder to remember that this was last week, so this week I want to take this dose. But if you are to take every morning, you get up, you pop a pill, forget it for the rest of time. So this is the first thing you are doing in the morning. So it's easier to fit into your routine.
Okay. Can we have one question from the audience if somebody wants to ask something?
So what we are talking here, this is approved for management of type 2 diabetes. This is not the dose approved for weight loss. If you look at the data from the oral semaglutide trials, the OASIS data was presented at the ADA meeting. So OASIS involved up to 50 milligrams of oral semaglutide. And 50 milligrams actually gives you weight loss similar to Wegovy, which is 2.4 milligrams of injectable semaglutide. Dose required for weight loss in obesity is going up to 2.4 milligrams, of Ozempic, which is injectable, or 50 milligrams of oral, which is some Rybelsus. The dose that is approved here is for diabetes, and Ozempic also is for diabetes. The dose is up to 1 milligram. But Wegovy, which is higher dose, is approved for obesity management.
How much is the weight loss in a diabetic patient with 14 milligram?
With
In a diabetic patient with 14 milligram of
So I showed you the pioneer data about 5 kilos
in comparison to the 50.
in comparison to
50 milligram of semaglutide. In comparison to the 50 which is used for the weight loss and in comparison with the approved dose for diabetic.
So diabetes dose is 14 milligram.
14, yes.
So if you go to 50 milligrams, the weight loss can be in the range of 15 to 20%. What you are getting here is about 5 kilos or 5 to 7% bats.
There is just one basic question, sir. You mentioned obesity and overweight. So how do we differentiate between these two things?
So body mass
Since,
index between 18 to 23 for Indian patients is normal weight or normal body mass index. 23 to 25 is overweight, more than 25 is obesity.
And second thing is that in many of our diabetic patients we have got a loss of lean body mass. So how do we compare that with the body reduction in weight we are considering for reducing the sugar levels?
Didn't get it?
Sir, in many of our diabetic patients there is already a weight loss. There is a loss of lean body mass because of uncontrolled diabetes. Then how do we compare it with the weight loss that we are targeting?
So
for
first
diabetic
thing
patients?
is, when you are talking of weight loss, you have to look at the control of hyperglycemia. Hyperglycemia correction is important before you go for weight loss. If you are starting weight loss, simultaneously you have to keep an eye on hyperglycemia correction. Even the approach that was adopted in the direct trial, patients were put on very low calorie diet. So very low calorie diet is not just weight for management. It also improves hyperglycemia very significantly. So if somebody is in catabolic state, what you are mentioning, hyperglycemia and catabolic state, I would try to put this patient on insulin, make him come back to the good metabolic state. But by and large, all Indians have lower lean mass or muscle mass. So all patients need exercise during weight management. If you don't make them exercise, you lose lean mass as well as fat mass. If they are exercising, they preserve muscle mass and lose fat mass.
Thank you.
Trial underway.
So OSS was presented, I told you, OSS was presented at the ADM meeting.
No, for diabetic.
So diabetes, this was done for obese people. But for diabetes, yes, in comparable trial with 2.4 milligram injectable is there. So weight loss in people with diabetes is lesser compared to totally obese population. Yeah, 50 milligram. Pioneer Plus, yeah. Pioneer Plus is there. Sorry.
Thank you so much, sir. I think we are already running half an hour late. So for our next talk, I invite Dr. S.K. Wangnu, sir, an alumnus of Banaras Hindu University and one of the most sought after speaker. He is presently the president of Endocrine Society of India and heading as a senior endocrinologist at the Apollo Hospital. Over to you, sir.
Thank you, Chairperson. I think after hearing Dr. Makkar, a wonderful talk, I am talking about the killing two birds with one stone. Now, the topic is slightly little bit fancy in the sense that initially I could not know what to talk about, which molecule, how to kill two birds with the one stone, and whether it is a molecule which protect your heart and kidney or something. So ultimately, I came to know that I have to talk about the role of long-acting basal insulin in the management of both outdoor patient and the indoor patient. So we are two birds, one outdoor patient, OPD, and one the indoor patient. So that means we will talk that one molecule, the long-acting basal insulin, how it is going to rationalize your treatment protocol in the OPD setup as well as in the indoor setting. Let's talk about the OPD setup. If you see the many trials in the literature, what all the trials have shown consistently, the proven hypoglycemic benefit in patients who are being treated as an outpatient with the basal insulin, the degludec. The begin was the treating to target trial in type 2 diabetes, and it was done in 40 different countries and in patients with the low risk of hypoglycemia while achieving the similar glycemic control. And the begin was in comparison with the insulin glargine U100. Switch 2 was a double-blind crossover trial among basal insulin treated patients, whether they were on glargine U100 and when they were switched to the insulin degludec. And DEVOTE was basically, it was a CV safety trial comparing CV safety of degludec, and it was a phase 3B trial. The U-treat type 2 diabetes is a real world evidence. It was basically in patient, the European patient that switching to degludec in broad population of insulin treated adult patient, whether they were type 1 or type 2. And this was a European multicentric retrospective non-inferiority study basically, and all the studies which I mentioned to you, that it has shown a very good decrease in the hypoglycemia, like overall 28% in begin, 30% in switch 2, and even 61% in U. That was real world evidence across all the European countries. So that is a, what you call the, an exciting thing that we have a low evidence of hypoglycemia, even your treating patient as an outpatient. Confirmed study, again a real world evidence, basically it was from the US population as compared to EU T2 diabetes, and it was a comparative effectiveness study of the degludec versus glargine 300, and they took the record from the EMR, electronic medical records, and outpatient basis, and it was seen the patient who were taking degludec has shown a significantly lower risk of hypoglycemia versus U300 glargine. Here their comparator was a U300 while in others were U100 glargine from the real world practice. So the changes in the rates of hypoglycemia demonstrated 30% lower rates of hypoglycemia with the degludec versus glargine U300, and change in the proportion of patients experiencing more than one episode of hypoglycemia was significantly lower with degludec. And also, not only the hypoglycemia, the within the variability, when you compare the degludec versus glargine U100, was better with the degludec, which gives round-the-clock coverage with the degludec, and also within day variability was better when the patients were on degludec. When we talk about the glucose variability, and there are various methods to basically measure the glucose variability, mostly the SD and the mean amplitude of glucose excursions, and there are various other indices by which you can measure the glucose variability. And in that data, it was shown that it was having significantly lower day-to-day glucose variability with the degludec compared to the glargine U300. Switch Pro, basically it was a CGM based data evidence comparing time in range and the nocturnal time below range from a RCT. It was a crossover study basically of basal insulin treated adult patient with type 2 diabetes, and you see the time in range was shown to be 70.7 in patients who are on glargine, and the time in range was 72.1 in patients who are on degludec. The difference of this from 70.7 to 72.1, and estimated treatment difference offers 1.43. Again, a very good treatment difference as compared to the glargine in terms of the TIR. Apart from that, what we have talked about, the degludec offers unparalleled flexibility. You know, the window period of taking degludec can be any, suppose you are taking this evening 6, next time you take 12 midnight, next time you take 4 o'clock. It's not necessary to take the same time as we usually tell our patients who are on glargine. So there is an 8 hours flexibility window with the degludec, and why glargine U300, the flexibility window period is anywhere between 4 to 5 hours. So it is slightly more flexibility as compared to the degludec. And also, it is having the lower dose as compared to the euglargine, and you know the BRIGHT study, we have shown the 23.5% lower dose with degludec in terms of the fasting plasma glucose reduction with degludec. So this is important that fasting plasma glucose can be also addressed better with the degludec as compared to the glargine. And not only that, better adherence, you know, the data from the US, basically better adherence, the likelihood of discontinuation on the OP basis of the basal insulin treatment in patients who were initially treated with degludec glargine, the discontinuation rate was much less in degludec because you have a lot of flexibility in patient. With some patients they come late, sometime early, so there was a problem in patient taking glargine. Now coming, we have killed one bird that we have found that the in OP patient the degludec works very nicely. Now coming to the inpatients, because nowadays everybody is treating inpatients. Before going into details about the inpatient degludec, let's see the difference between the degludec, glargine U100, glargine U300. If you see, the degludec has a faster onset of action and prolonged duration of action as compared to the glargine. It has more than 42 hours, where the glargine 300 is up to 36 hours and the glargine U100 is up to 24 hours. So this is important that it has a longer duration action, and we have a lot of data in the literature about the evidence of degludec in terms of better glycemic control, in terms of low hypoglycemic rate, and in terms of better achieving the target of HbA1c in the hospitalized patient. One of the trial, what we call the degludec hospital trial, which was basically to see how the degludec, when you titrate the dose in hospital setting, both in the medical and surgical in-hospital patients, when they measured the mean glucose after day 1 within the ADA criteria of less than 180, the degludec was much better on day 1 and day 2. And also in the IDEOS study basically, which was an in-hospital prospective observational study, they had basically shown a significant reduction in fasting capillary glycemia, which was achieved with the insulin degludec. It was basically the capillary glucose measurement. Now coming to the better predictability with the insulin degludec, the data was basically by Simeon et al., which basically appeared in Diabetes Therapeutics, and this is basically an observational study where they took the mean blood glucose at the time of the admission and the mean blood glucose at the time of the discharge. And if you can see, the mean glucose from 237 came to 152 at the time of the discharge. So that was a very good, difference between the in-hospital patients who are on degludec as compared to the patient who are on glargine. So this is important. Another study, the degludec euglargine versus glargine U300, which was presented in Endo 2022 by one of our own colleague, Shafiq Uchai, who had worked in Vedanta. Basically, it was a study to show the efficacy and safety of the degludec U100 versus glargine U300 for the hospital management of patients with type 2 diabetes, a prospective. It was an open label study with a non-inferiority randomization trial. And you can see how the randomization was done in patients who were put on degludec plus insulin glucosamine basal bolus therapy vis-a-vis glargine U300 and the glucosamine, again a basal, and then they show the during hospitalization and the post-discharge endpoint. First of all, a rapid improvement, because you know the rapid onset of action, a rapid improvement in glycemic control with the degludec. You can see the blue line below the red line of glargine U300. And also the fasting mean glucose was better controlled with degludec right from the very beginning, and it has a very the margin between in the pre-breakfast blood sugar because of the fasting. And then the more percentage of blood glucose reading is within the range, time in range. If you see the mean blood glucose between 70 to 140 and 100 to 140 was much higher in patients who are on degludec during hospital stay as compared to the glargine 300. So this is a molecule, safe, easy to administer, and you can use in a wide range of the patients. Uncontrolled diabetes, renal impairment, hepatic impairment, LD and pediatric patient. It has a flex touch pen, no push button extension, unique injection mechanism, very low dose force, end of the dose click, accurate and consistent dosing. To summarize my talk, two birds, outpatient and inpatients. I have told with the various data shown that in outpatient it has a proven hypoglycemic effect, lower within day and day-to-day variability, unparalleled flexibility in dosing timing, more time in range, lower dose requirement, better adherence versus glargine. In patients, early onset of action because the hospital stay may be too short, and rapid attainment or control within 2 or 3 days. Ease of daily titration, low glycemic variability and better predictability, unparalleled flexibility in dosing timing, safety and wide variety of population, convenient and the friendly device. Thank you very much. And because this was a company sponsored talk, so we had to mention that get some honor from the company people. We had to declare that. Thank you very much.
Thank you so much, sir. Sir, just have one query from you. Traditionally, in the IPD setting, the traditional choice, majority of everywhere is a basal bolus regime with glargine as traditionally be the choice of insulin. So, are you sensing a change in practice, or what do you think are the impediments to the use of degludec in front of?
Well, over the last few years, what we have seen, we have started changing our protocol from the basal glargine to the degludec to see what is the impact, whether we are able to attain a quick glycemic control to the patient admitted for 2 or 3 days, and after the discharge, because of a lot of flexibility in the timing, we are finding it very easy practically, and my clinical experiences shows that now we are almost all the patients we are discharging on the degludec because no fear of hypoglycemia, the flexibility is too much, and I think cost-wise not any much difference.
I think that I think the second stone which you are talking about is something which needs to get percolated to the masses, because the use of degludec in IPD setting is still somewhat.
I think all depends on experience. You can form your own protocol in the hospital setup where you are working. It's just to see, seeing is believing. It's not, don't read the literature. If you see, if you are doing in hospital setting and you are getting the result, then you should believe it. Don't go by the literature. That's why I always want to first try in my patient and see whether the data is correct or not, whether we can translate into the real world evidence. So that is why then we start continuing the patient on degludec.
Sure. Thank you, sir. Is there any question from the audience? Okay, we can have the discussion after this session. If there is some questions.
Over.
Now, if there is any question, people might have been coming out late. So, for our third talk, may I invite Dr. Rucha Mehta, who is again a consultant endocrinologist, and she is the director of cardiometabolic department at Apollo Ahmedabad, and she has been a part of the RSDA working committee member for writing the obesity guidelines for the consensus panel, and she'll be talking about tackling the stigma of obesity. Over to you, ma'am.
Good morning, everybody. Thank you so much. And after 2 sponsored talks, you are going to hear a very social talk, I feel, a socialist talk, I should say. So when I was given this talk, since obesity is something very near and dear to my heart, and being on the executive committee of the Aero this year, I really think this is an important topic. Some of us may not know what a change this is making in the way we approach obesity or the treatment of it. You've heard all about the molecules available to you or not available to you, but in the pipeline. But what is the stigma of obesity? So in the next several minutes, I hope I can change the way you think, just like our commander-in-chief who thinks outside the box. So I told Dr. Makkar, you will see my disclaimer is very different from everybody else's disclaimer prior to me. And it really did change the way I will approach my patients when I started making this topic. And we are making a lot of noise about obesity this year and how we need to work on weight management and health, and not simply weight loss should not be our target. So whenever the topic stigma comes up, I thought I'll break it down simply as what is stigma? Why should we know about this? And if the why is clear, I hope how will you approach and tackle this problem becomes absolutely clear. So what is a stigma? I went back to Merriam-Webster's dictionary as we used to do in school, and it says stigma was something like a mark or a brand. Back in the day when you were tortured with, branding with a hot iron rod, and the tattoo it created was called a stigma. That's how bad the word stigma is equivalent to torture. And imagine considering obesity. So what are some of the stigmas you can think of in recent time where we were all shunned? Can anybody name something that happened that changed the world in the last 3 years? So I'm hoping someone will say COVID-19. Yeah. So, so COVID-19, if you remember, it was almost a stigma in the first 3 months of the wave. If you even coughed or if you were diagnosed with COVID-19, that entire family was stigmatized. Nobody wanted to see them. As doctors, I was going to Apollo Hospital every day. The minute I came back, all my family members ran into their rooms till I, had those little buckets. You put your bag, you put your purse. My timer has not started. The timer has not started, our excellence, yeah. So I would run into the room, shower, then maybe they'll see me. They may not see me. I was in my room in spite of not contracting the disease that time. So you can see this is a guy who is being shunned by COVID-19. I thought let me take some simpler topics to explain what stigma is before we get to obesity, which is the size of an individual. How can that be a stigma, right? And of course we know about racism, poverty, so many things in India that have gone on forever. It's almost, I don't know how to talk about it without somebody taking a video and posting it on social media saying I'm approving it. I'm not approving it, I'm just bringing it up. Leprosy, for example, look at this beautiful, and this is all the way from the 1900s, saying the stigma of leprosy was more contagious than having the disease itself, right? So this is something we have to really think about. Now this in the modern day era, we see these bathroom signs. Does anyone see? She, her, he, him, they, them, right? Nowadays when you attend Zoom calls, automatically in my name it comes up she and her. You have a choice to put that, and this is, you can see the skirt on this lady, the male, and you can see this because sex is a choice, it's not a stigma, which gender you want to follow. So these are so many things happening in society today. But to explain, can I have audio on this video over here? Excuse me. I had asked them, so I want to just show you a video from a popular movie, Kal Ho Na Ho, wherein Preeti Zinta is telling her friend she's not going to get married because,
जब तक तुम्हारा वेट रिड्यूस नहीं होता कोई लड़का वड़का नहीं मिलने वाला तुम्हें मैं कोशिश कर रही हूं ना नैना वो तो दिख ही रहा है
while she's eating that burger.
He's so cute नैना वो तुम्हें क्यूट लगता है तुम तो कोई भी
Okay, so you can see even in this, in our movies, why is being overweight stigmatized? This is, and you don't realize this, but at a subconscious level it plays on our mind that maybe being overweight will not get me a boy for marriage. Childhood obesity, and you know what, it was very funny when I was looking for cartoons for obesity stigma, all of them had women. All the cartoons I could find, there was nothing with men in it. So even women are stigmatized more for being overweight and obese than men are. This is a stigma, a sub-stigma by itself, a subcategory within obesity, I would say. Called fat by schoolmates, 12-year-old girl kills herself. This is in Times of India recently. I mean, it starts so early, so we need to work at the pediatric and the adolescent levels. And we already have seen data from Dr. Makkar's talk that obesity and overweight is increasing in our country. So are we going to stigmatize more than half of the population? Where are we going with this? What is the ultimate goal? We need to think of people as a whole, because the global prevalence of obesity, as Dr. Makkar showed you, 650 million people worldwide, more than a third or 20% of that living in India. And who is this impacting? Not just adult men and women, urban children. You'll be surprised that the rural areas have just as much or more overweight and obesity as compared to the urban areas. And what if I just tell you this is the tip of the iceberg? Because all we are seeing is just measuring BMI, whereas what should we be measuring is in India, the abdominal obesity, and those numbers increase from 250 million to 350 million. So this is staggering. Are we going to stigmatize all of this? Keeping this in mind, the World Obesity Federation and all the leading bodies have actually now made this a movement that weight stigma, wherein you discriminate against the obese individual, can lead to internalized weight bias, negative ideologies, low self-esteem, and prevent the patient from taking care of themselves, perpetuating the vicious cycle of obesity. The American Association of Endocrinologists has also put forth a consensus statement and explained what weight bias is and what weight stigma is. And we need to really understand this. I was surprised to find at least 3 guidelines. I thought I'll find none, honestly. I was surprised to already find 3 existing international guidelines for this. Now here's when they did a study with a very popular program known as Weight Watchers. Almost 14,000 adults underwent a very anonymous survey, and they were asked if they ever felt stigmatization, whether they didn't get what they should get, meaning I don't get the right job, I'm not included in sports, I don't get an opportunity. And then they were asked across their age, across their lifespan, when did they feel stigmatized? The highest numbers were in childhood and adolescence. So imagine if children are feeling stigmatized, so they said that that's when they felt, and in adolescence, and they seemed to handle it better as they got older. And this prevalence was 66% in this 14,000 cohort patients. So the prevalence is increasing. It is being compared to racial discrimination. It's more in women than in men. No wonder I found all those cartoons with women in them. Now, where does this weight stigma occur? Everywhere. Family and friends, mothers tell their daughters, "Arey wazan kam kar lo, shaadi nahi hogi." It starts, you hear this and you're shocked, It happens in school places, it happens in healthcare. Employment, getting lower wages, airplanes. You have to buy 2 seats. Had you read this recently in the newspapers? If you're overweight or obese, you may have to buy 2 plane tickets, 2 seats in the plane. So this is happening everywhere. And this is one of the studies of obesity at work showing that white females who were heavier than their counterparts got 10% lower wages. Black women as well as white obese women got less salaries. Men did better than women at work, especially if they were thin, good looking and leaner. So these are staggering things to think about, which we ignore based on body size and not on your qualifications. Books. Look at this thing from Harry Potter. Everybody knows Harry Potter. What is Harry doing? He's serving cookies to the Dursley family who was supposed to torment him. What does the Dursley family, what do they look like? They are made to look overweight and obese eating cookies. So meanness also within books that children read is being linked to this. So this is a stigma again, that being overweight always means you could be mean. I mean, doesn't that sound really silly? Now this is one of the most important slides I feel for all of us as healthcare professionals, and the next study I'll show you. 2,600 patients who had overweight or obesity underwent a survey, and they were asked that where do you feel this stigma? And they felt the highest stigma was reported that the patients experienced, say, from doctors, nurses, dietitians and nutritionists and mental health professionals. So where are these people going to go for help? And of course, we also looked at classmates, sales clerks, friends, co-workers, but the highest stigmatization was that doctors do not give them equal treatment, consider them lazy, less motivated, and therefore this affects their treatment care if doctors are stigmatizing against their own patients. This is seen across the board in dental students, medical students, and is pervasive even to the level of nursing students. So we need to change our mindset. This is a very interesting study done again amongst exercise and nutritional professionals. Even dietitians and exercise professionals were seen to stigmatize. As you can see over here, 85% evidence amongst the professionals practicing physical therapy, and almost 73% amongst the nutritional professionals did not give appropriate treatment to patients, or the patients felt stigmatized. Now, here is a study done at a conference like ours. People who were coming to the conference were asked to fill up a survey, researchers and health professionals, and they were specifically obesity care health professionals. Okay, the samples had, so the doctors or the healthcare professionals were almost about 400. 90% had a graduate or professional degree, and all of them were doing some obesity related work. Now what did we find? By doing a very interesting test, if you have time, please read about it, called the implicit association test, which allows us to know prejudice towards the target group. Okay, and you are given this kind of surveys to fill, that thin people motivated, yes, no, fat people lazy, yes, no, or do you think they are slim, eager, etc. And they do 4 kinds of these surveys. And what did we find? This is in the gray is positive and black is a negative attitude. You can see across the board obese people were having negative attitude. So this was really interesting to see. Even people who deal with obesity amongst this subgroup are doing this. So the network is complex. Many things are happening. We need to work at several levels. Let me now show why we need to do this. Because this prejudice and stereotyping perpetuates the vicious cycle of obesity, and what we now need to call it as an ABCD or adiposopathy based chronic disease. We don't even want to use the term overweight obesity. We don't want to say lose weight. We want to say get healthier. If we don't do this, we are going to perpetuate a lot of vicious pathways. Weight stigma leads to internalized weight bias, which will make them again go into the vicious cycle of overweight and obesity. Therefore, screen for this and try and give them psychotherapy and cognitive therapy early on for better responses in these patients. Besides looking at biological factors, which we are all good at treating, diabetes, blood pressure, cholesterol, please take some time to look at their social and psychological factors as well. Because if you don't do this, the weight stigma or bias leads to stress and increased weight gain, and leads to a decreased healthcare quality, not at personal individual level, but also becomes a magnitude of public health potential and public health level. The association between weight stigma and mental health has led to more than 60% reason for mortality and suicide risks. So these are some staggering numbers that we need to be worrying about. A very nice article, if you get the time, Obesity Stigma, Causes, Consequences and Potential Solutions, wherein they go through all of this and talk to you about how you can prevent morbidity. So it's a very nice article just off the press last year in December 22. I just wanted to show how will you do this. So in UK, in the Doncaster model, in a town called Doncaster, what they decided to do is focus on this cognitive behavioral therapy, wherein they started with the individual or your obese patient, saying you're already good enough and you are valuable. You need to be compassionate and empowering support, and you need to promote health management more than simply weight loss. Therefore, make them focus on things other than simply weight loss. We need to start early. So complexity and stigma of pediatric obesity, as I already showed you, weight related bullying leads to an increased stigma and a risk of eating disorders. Therefore, we need to start early so we can prevent this. Knowledge gaps and attitudes in physicians and healthcare professionals need to be addressed. We need to make sure professionals understand where they are coming from and be more empathetic towards these patients. So I'll just end with letting you know that these are these joint international consensus statement guidelines with all the top thought leaders in obesity on them. The ACE also has this guideline statement wherein you have a lot of exercises you could help your patients with. You need to follow this chronic care model so that you have an empowered patient. Therefore, you can prevent bias for optimal outcomes. I can't go in the details of all cognitive therapy. It's beyond the scope of the talk. We already spoke about important considerations of public health. I think leaders in our country, and as I'm part of executive committee, will make it one of our points to work on body positivity, education and legislation so we can empower physicians and providers to do this for the same. So I think the sumo wrestlers are the best example of body positivity. They are huge in size, but they are very healthy, as all of you will know, and they are very, very active. There's a lot of this modeling happening now with plus size models also. I think it's a great movement. And I'm going to end with, also we have heroes to the rescue who are going to help us take care of this.
जो लड़का तुम्हारी फिगर को देख के तुमसे प्यार करेगा,
वो अंधा हो,
वो गलत करेगा, इग्नोर हर. उसे तो डीपली तुम्हारे दिल के अंदर झांक के देखना चाहिए.
You're right, you're right.
I'm always right. एक बात बताओ, यहाँ पे कोई लड़का है जो
Okay, so that's sort of what we are saying is that Shah Rukh Khan is to the rescue, and he says, you know, he needs to love you not for your body size, but he needs to go deep into your soul. So I would say health matters at every size. We are all people. We can't be, you know, stigmatizing by giving names as, even thin, fat or everything. And this is World Obesity Federation has come up with this End Weight Stigma logo. Thank you so much for your attention. Yeah.
Thank you so much, Dr. Richa. I think this non-disclosure presentation which you have given is actually the need of the hour and touches upon a topic which actually should be more discussed. Even now in the medical curriculum, the attitude, communication and ethics has come out in a big way. And I think your talk may be the starting of a paradigm shift in the way we deal with our patients' obesity, not looking at only the numbers in terms of weight and the obesity, but also the social and the psychological aspect, which actually is more, I think, more important than the other things. Thank you so much.
Thank you. Yes.
Can we have any question from the audience, or shall we move on?
If we have a comment from Dr. Makkar, I think so, because he's also here with us from the Aero
Sure.
Committee. So.
Richa's presentation don't need any comment. She is one of the stars in obesity field in India. She is one of the I always thought there is hardly anything we are able to do in obesity, because I started working in obesity very early. But once she came in, she showed that lot can be done in obesity, and she is doing phenomenal work.
Thank you so much, sir. Thank you.
So that brings to the end of Symposium 1. May I now request the chairperson to hand over the memento to Dr. B.M. Makkar, sir? Sir, on the stage, please, for the memento. I think Vangnu sir has left. So may I now request Makkar sir to hand over the memento to Dr. Amitesh?
Yes.
Give me a donut.
Good morning, ladies and gentlemen, and distinguished guests. Thank you so much for the enlightening session and bringing the depth of understanding you've brought to the symposium. To chair our next Interchangeability Symposium, I would like to call Dr. Girish Khurana, consultant physician and diabetologist, founder and medical director of Vidya Medicare Center, Delhi, NCR. I would also like to call upon Dr. Kirti Suta, consulting diabetologist, diabetes physician, Dr. Makkar, Diabetes and Obesity Center, New Delhi. Over to the chairpersons for further proceedings.
Good morning, friends. So today we are having a very important symposium on interchangeability by Dr. Sameer Agarwal. Dr. Sameer is a head at Apex Plus Super Specialty Hospital, Rohtak. He is president of Speed Society and he has a number of awards and publications to his credit. He is editor of Insulin Manual and Manual on Pregnancy and Thyroid Disease. So without taking much time, I'll ask Dr. Sameer to start with his deliberations. Over to you.
Thank you, Dr. Girish, for nice words, and thanks to organizers for arranging good academic events. I think basal insulin is part and parcel of basal bolus therapy, which most of type 1 diabetic patients they are on. And many type 2 diabetic patients are not controlled on combination of oral drugs and they need to be on insulin. And we know that type 2 diabetes is a progressive beta cell secretory defect, so many type 2 diabetic patients will require insulin at some point of life. And there is a delay in initiation of insulin. There is issues with regards to acceptability of insulin use also. And we have seen type 2 diabetic patients spending a lot of time with higher HbA1c before they are put on insulin. There are many concerns with regards to insulin initiation in type 2 diabetic patients. They have some myths with regards to insulin use. Cost factor can be one of the issues. Issues related to hypoglycemia, weight gain, complexity of the regimen, these can be further issues. So when you initiate insulin in type 2 diabetic patient, it's very important that less the complicated regimen is, more acceptability will be there for the patient. So it's always better if we can initiate a basal insulin like glargine 100 IU per ml. And we have been using this insulin since years. Many years back, we didn't have choices except for one basal insulin, longer acting like glargine. Of course, we had NPH since years also, but that's not truly a basal acting insulin. And now we have many biosimilar insulins like Basalog from Biocon. So, and we have seen that initiating a basal insulin is taking care of fasting as well as pre-meal glucose levels, and many a times it takes care of the glucose profile. Once you fix the fasting, even the postprandials are corrected. So biosimilar insulins, what's the data about that? Should we be using these insulins in type 2 diabetic patients? They are good in quality as compared to the standard reference insulin? Are they equal in potency, safety and efficacy with regards to the innovator insulin? So there has been adequate data. There has been a lot of FDA approvals, and there has been a lot of talks about the interchangeability of a basal insulin. So we will be touching briefly on some of the studies and some of the data for next 10 to 15 minutes. I will not be long in my talk. So there is need for early and timely insulin initiation. That's what I am talking about. We do not want type 2 diabetic patients to spend a lot of years with higher HbA1c. Type 2 diabetes is a disease. In fact, they say by the time you diagnose type 2 diabetes, patients have already lost somewhere around 40 to 50% of the beta cells. And till date, we do not have an oral therapy which can regenerate beta cells. In fact, once we initiate insulin early on, that seems to be decreasing glucose toxicity, and that can be beta cell protective also. And poor glycemic control puts patients not only of type 1 but of type 2 diabetes also at risk for complications. So early insulin initiation, once you feel that patients are not responding to combination of oral drugs, is always important. And we have data right from UKPDS for type 2 diabetic patients, and also from the DCCT trial also, that intensive glycemic control leads on to decreased microvascular complications. Each 1% HbA1c reduction decreases the microvascular complications by around 35 to 40%, myocardial infarction by around 14%, and also death related to diabetes. So this is the summary of the major clinical trials that UKPDS, in fact, where the patients of type 2 diabetes were relatively new onset, and intensive control led on to decreased microvascular complications also, and also on long-term follow-up there was some effect on myocardial infarction also. In fact, DCCT trial, ACCORD, ADVANCE, all clearly showed that intensive control definitely helps in decreasing microvascular complications. So this is what we have seen in our practice, that inertia with regards to insulin initiation, insulin intensification, and continuation of insulin. And you can see across the world type 2 diabetic patients are spending a lot of time with higher HbA1c. In fact, there has been studies showing that they are spending from 6 to 8 years with higher HbA1c before they are initiated on insulin. So this is not called for in today times when we have evidence that intensive control will improve the microvascular complication scores, and if the type 2 diabetic patient is spending a lot of time with higher HbA1c, he is going to land up into complications. So there is a inertia. This is again why the inertia is there, whether it is at the level of physicians, whether it is at the level of patients. So that has to be taken care, and each individual of type 2 diabetes will have its own concerns, and we should not be depriving the type 2 diabetic patient with benefits of insulin because of cost issue. So 2020 insulins were classified as biologics. So before that, most of the insulins, in fact, they were called as drugs, but in 2020 the definition changed. They were classified as biologics. Biologics are larger and more complex than traditional small molecules. They are biologics. If we see the basic differences between the drugs, biologics are produced from living organisms. They have comprehensive physiochemical analysis and bioassays, and they are sensitive to temperature and manufacturing conditions, and they can be associated with immunogenicity. That is what we always talk about, that whenever you are developing a biosimilar or any other copy of a true biologic, we should always be checking on the efficacy, potency, purity, safety, and immunogenicity. These should have to be there. So there are many terms like biologics, reference, follow-on biologics, biosimilar. So each of these have subtle differences. Biologics, true reference biologics is like, if you talk about in simple words, Sanofi developed Lantus. So that's a innovator biologic which was developed. Then came follow-on biologics. Follow-on biologics, if I talk about Basal is a follow-on biologic. Then if we talk about biosimilar, Basalog from Biocon is a biosimilar. So it has underwent various pharmacokinetics and dynamic studies. It has, Biocon's Basalog has underwent head-on comparisons with the innovator Lantus, you can say. So it's not that the approval process for biosimilars are weak in position as compared to the innovator. In fact, there was a position statement from FDA. If you Google it, you can see that they have clearly told, in fact, the approval processes of biosimilars are in no way less. In fact, they are very strong as compared to the launch of biologics. So biosimilar insulin is a drug which is not exactly the copy of the true innovator biologic, because they have different manufacturing processes. They are produced from living cells or organisms, and they are not, we cannot say that biosimilar is equivalent to a bioidentical, biomimic or biobetters. These are not terms to be used with regards to insulin. So these are again terms like switching and interchangeability. In fact, these terms are, I think, very prevalent if we see US and Canada, because there the pharmacist cannot substitute any product. In India, of course, it's altogether a different scenario, but clearly with the approval of biosimilar insulins, now we have just biosimilar glargine with us, and now you will have other biosimilars also coming up in next few months or maybe next 1 year. We can have a rapid-acting analog also coming up. So you must understand, in US they say if any insulin has a label of a biosimilar insulin, the pharmacist has power to change that insulin without the permission of the prescriber. But if insulin has a label of a follow-on biologic, it's a copy but has not, it's a simple biosimilar, then any pharmacist cannot substitute it without the permission of the prescriber. So we have to be clear with regards to regulatory definitions. So if we talk about Biocon's insulin glargine 100 IU per ml, we can see across the world it has underwent various strict regulatory protocols, whether we talk about Australia, India, or western part of the world. So across the world it has underwent various studies and regulatory approvals are already in place. So if we see the Basalog from Biocon, it has been tested in around 1900 patients across 20 countries. So basically we see what these are the 3 INSTRIDE 1, 2 and 3 studies. You must have gone through these studies also in various Zoom meetings and other meetings also. So in INSTRIDE 1, the primary objective was to compare the efficacy and safety of Basalog as compared to Lantus that was in type 1 diabetic patients. So it was to determine whether the Basalog is non-inferior to Lantus when administered in combination with rapid acting analog, that is Lispro, in patients with type 1 diabetic patients. So around 500 type 1 diabetic patients were there, 18 to 65 years of age, and treated with once daily insulin glargine for at least 3 months. Follow up, and we can see that if we compare the blue lines versus the red one, blue is for Basalog, red is for the Lantus, that's closely matching if we talk about HbA1c or if we talk about the fasting plasma glucose. So the difference between Basalog and Lantus is not there. There was no statistically significant differences in actual HbA1c on follow-up. So both insulin doses of Basalog as well as for the Lantus did not differ between the groups, and rates of hypoglycemia and other adverse events were quite comparable. This was about type 1 diabetic patients. So do we have data for type 2 diabetic patients? Again, the INSTRIDE 2 study, these are all published in good diabetes, obesity and metabolism journals, where again the objective was to study the non-inferiority to compare the efficacy and safety of Basalog with Lantus in type 2 diabetic patients. So here around 560 type 2 diabetic patients were there. Stable dose of oral hypoglycemic drugs was already there, and again 4 weeks follow-up was there, and primary endpoints were there, like change in HbA1c from baseline to 6 months, change in fasting plasma glucose, hypoglycemia, any immunogenicity were the secondary endpoints which were studied. And again, as we saw the data for type 1 diabetic patients, HbA1c was quite similar between the two insulins, Lantus versus Basalog. So the doses of glargine also in the two groups was quite similar if we see the gray as well as the blue lines. So other adverse events like hypoglycemia were not significantly different between the two groups. So this is very important study that is called as INSTRIDE. So INSTRIDE 1 and INSTRIDE 2 led to the label of insulin of Biocon like Basalog as a biosimilar insulin. Then the question which was pending was that should it be labeled as an interchangeable biosimilar insulin. So FDA requires that whenever any insulin has to be labeled as a biosimilar insulin, it has to undergo switch studies. So this was a beautifully designed study where efficacy, insulin dose, safety and immunogenicity of Basalog was studied in type 1 diabetic patients, switched between Basalog and Lantus insulin. So this is a 4 and go switch off where two groups, one is on Lantus, the second group you start on Basalog, then you again put them on Lantus and again come back to Basalog, and you see what happens across after the follow-up. We see the change in HbA1c is quite similar as compared to Lantus at both the lines. And if we talk about hypoglycemic event, there was not any difference between the two insulins. And if we talk about immunogenicity, that is developing of anti-insulin antibodies, again there was no difference. So good data from INSTRIDE 3 led on to this Basalog for the first time being labeled in 2021 as the interchangeable biosimilar insulin. So that was in sort of a breaking news for this insulin. We have some India switch study also, still not published, but again the results are favoring in the same way as the INSTRIDE 3 study, where you do not see any difference with regards to efficacy or with regards to side effect profile between the two insulins. Of course, more real world data is required for this. So I think with the availability of biosimilar insulin, you can have a cut down on the costs. You can initiate this biosimilar insulin in type 1 diabetic patients, type 2 diabetic patients, secondary diabetes also. It can improve the cost of the therapy also. So to conclude, the approval process of a biosimilar insulin like Basalog is definitely streamlined. This Basalog is the first interchangeable biosimilar insulin to be compared with reference insulin glargine, and based from evidence from clinical trials, the purity, efficacy and safety of Basalog is absolutely same as compared to the innovator Lantus insulin, and we can have our type 1 diabetic patients and type 2 diabetic patients on this insulin seeing the robust data of Basalog. Thank you.
Thank you, Dr. Sameer, for an excellent deliberation. May I request you to please join us on the dais? So before we start the discussion, Dr. Sameer, you have rightly said that biosimilars, they are equivalent to biologics, and you have proved it with various studies in type 1, type 2 and immunogenicity study in type 3 also. So my question to you is, now where is the compulsion to start with biologics? And in what situation you will start biologics when biosimilars are there with at a lower cost and with having a similar efficacy, duration, everything is almost non-inferior to biologics?
So very rightly put up question by Dr. Girish. So you have two choices, three choices. You can start a patient on a reference biologic, true biologic like Lantus. You can start a patient on a simple biosimilar. That is, I think we have a Basaglar with us, or maybe you can say Basugin also with us. And your third choice is you can start a patient on Basalog. The cost of the therapy, I think, is less. If we see, you have in fact a Basalog vial also, which is, I think, absolutely the cheapest glargine available in the world at the moment. And if we talk about head-on comparison between these three insulins, we are with the INSTRIDE 3 studies, INSTRIDE 1 and INSTRIDE 2, except for the Basalog from Biocon, we do not have such data from other glargine or biosimilars at the moment. And if I talk about the INSTRIDE 3 data, the switch studies which led on to approval as interchangeable, no insulin except Basalog has this data. If we talk about Basugin, if we talk about Basaglar also. So in India, you have all the choices. In fact, you can use NPH also as a basal insulin, which is again cheap, but it has its own issues. But I think with the robust data of Basalog and the cost of therapy coming down, and many patients are on insulin doses of basal insulin like 40 units, 60 units. So the cost is ultimately be good for, will be beneficial for the patient, especially if they are on high doses. So that's, I think, my take with regards to initiation of a biosimilar insulin.
Any question from the audience?
So starting with modified insulins, instead of these basal insulins, twice a day injected are giving better results, 24-hour coverage very well. And today our patients are definitely affording this. So what you will see vis-a-vis.
Where you compare with which insulin?
You see, you just told about Lantus or glargine.
Yes.
And other modified ones
yes.
that are given twice a day.
So NPH, yes, you can give. It's a very cost-effective basal insulin. It has its issues, like there is always be a peak with NPH. You have to reconstitute it. Then again, it's not a truly 24-hour acting insulin. In many patients, you give it twice daily. So
Of course,
that's
it is given twice a day.
yes.
Regularly we are giving.
Yes. So if you talk about type 1 diabetic patients or patients who are on basal bolus therapy, more the number of injections, I think acceptability goes down, compliance goes down, so it becomes quite uncomfortable for the patient. And again, time of therapy with these basal insulins who are 24-hour acting insulins, you can have sort of a flexibility also. It's not necessarily to inject 2 hours after the dinner. You can inject it in the morning also, maybe 1 hour after the dinner also. So flexibility is not coming up. So this reconstitution, NPH is a cloudy insulin. Many a time patients are not reconstituting it. So then it again becomes an issue with NPH insulin. But yes, patients who are not able to afford, and we use it frequently in our type 1 diabetic patients and type 2 diabetic patients also, both cartridges as well as vials.
Chances of hypoglycemia are also less. Yes. Plus, NPH is being used in most of the government centers where it's available. Otherwise, on CGHS panel, we use long-acting insulins.
Very nice talk, Dr. Sameer. My question to you is that is it not too early to consider biosimilars, because still we need to see some long time side effects. Secondly, in biosimilars, some severe hypokalemia has been seen where patient has to be hospitalized. So if we consider cost and hospitalization, biosimilars become a little expensive. So what's your take on this?
I think, sir, if we see the regulatory procedures of biosimilars, there is no doubt that once, because these are FDA approved regulatory processes, they are very stringent, they are very strict. It's not that in months you get a approval for any insulin as biosimilar. So they have underwent quite strict protocols, and you can go Google it. If you see the regulatory, it's clearly written even on the Pfizer site. In fact, they say the regulatory procedures are very strict for any insulin to be labeled as interchangeable biosimilar. I am not talking simply about a biosimilar. There can be many biosimilars, but once you label any insulin as interchangeable biosimilar, in fact, the Pfizer site with the reference also mentions it that, in fact, the regulatory and developmental processes are very strict as compared to, in fact, the regulatory process for a true biological insulin. So I am very clear that these regulatory processes are definitely in place if with regards to FDA.
I think the only issue left was immunogenicity.
Yes.
Which has been clearly addressed in STRIDE 3
And
study.
hypokalemia can occur with any insulin. It's not necessary. In fact, this is one of the treatments for sometimes hyperkalemia in CKD patients also. So any insulin can cause, but usually it will not cause until and unless you are giving very high dose as IV insulin infusion. Subcutaneous insulin is, I think, not going to cause any significant hypokalemia.
Is there any study done along as a basal bolus with biosimilar?
Yes, sir. This was the in STRIDE one was the type 1 diabetic patients. It was a part of a basal bolus therapy also. So the clear-cut data is there.
So if there are no more questions, I'd like to thank Dr. Sameer for an excellent presentation and answering the queries of our audience.
Thank you so much, sir. May I now request Dr. Girish Khurana to present the memento to Dr. Sameer Agarwal, please. I would now like to call upon Dr. Pooja Relia to hand over the memento to our chairpersons, Dr. Girish Khurana and Dr. Kirti Suta. Sir, please, you can answer. May I now request everyone to join us in the MMS Ahuja Hall for the inauguration, the next hall. Should we start, ma'am? Welcome to the post-lunch session. I hope you all are awake. Had your coffees? Well, continuing the momentum of enriching discussions, I am pleased to call upon our chairs for the next Basal Insulin Symposium. Let's welcome Dr. Pooja Relia, Senior Consultant Medicine and Unit Head, Maharaja Agrasen Hospital, Punjabi Bagh, and Dr. Seema Shahi, Consulting working as Head Medical, BSES, Rajdhani Power Limited. I request the chairs to please begin the next session.
Good afternoon, everyone. And taking the discussion forward, I would just like to introduce our first speaker, Dr. Surendra Kumar. Sir needs no introduction. He has been the chairman, Department of Endocrinology and Metabolism, Sir Gangaram Hospital, and is the advisor till date. And sir has served in the Indian Army for past 25 years. And I have had the association with sir when I've learned from him as an under and postgraduate student at R&R Hospital. I would like to request sir to please come and join us.
Good afternoon, friends, and thank you for the kind introduction. I'll be talking about the basal insulin and how we proceed forward. We know that diabetes is full of complications, and it's very much possible to prevent or delay the complications, but for that the patient has to sacrifice few things, has to maintain a very strict control. Strict control on 3 points. One is good control of blood sugar. Number 2, systolic blood pressure especially, and number 3, cholesterol, especially the lipids, LDL. Now controlling lipids is easiest. Next is controlling blood pressure is again comparatively easy, but controlling glucose is most difficult because the number of factors which are involved in the control of glucose, especially the postprandial glucose, are tremendous, are so many, and that's why it becomes extremely difficult. In addition to that, lifestyle modification, drug therapy, and probably monitoring. Monitoring is another factor which is often ignored. But for control, we need to have good, adequate, and that monitoring. That means A1C should be well controlled. And in addition to that, there are other factors which I shall be dwelling on. Now, we all been thinking that for the prevention of complication, for prevention of or delay of heart failure and acute myocardial infarction, number 1 is lipids, number 2 is hypertension, and last of all is glycated hemoglobin. But the fact is, all this information was till 2005 or 10. The newer studies have come up, and this is one of the fantastic studies, Swedish registry evidence, along 3 lakh patients followed up for a duration of around 13 years here. Now, if you see clearly on the first line, when we talk about death from any cause, here the glycated hemoglobin comes fourth. Now look at the second, acute myocardial infarction, glycated hemoglobin top, stroke, glycated hemoglobin top. And when we talk about heart failure, there are of course atrial fibrillation, body mass index, physical inactivity, and kidney failure. They become on the above side as compared to the glycated hemoglobin. So in this, the LDL is much lower down. So this means that something has happened during this period, last 10 years or so, that from position number 3, the glycated hemoglobin has moved to position number 1. And thus it was found that it is the variability which is important. It is the variability and other factors which play a very important role, and A1C has to be a good type of A1C. Now this information again, whether the variability is important or not, then after DCCT, when publication was there in 1995, they found 2 groups of patients, both having A1C 9. In one, the retinopathy was around 23, in another retinopathy was around 8%. So this led on to a lot of speculation that what is this? Then in 2001, American Journal of Physiology, they came forward that probably it is a glycemic variability which is responsible for the different results like that. And in 2003, the same group again found out that probably it was PKC activation which is responsible. And PKC activation is due to oxidative stress. Now came the idea that if that is the case, let's activate PKC and prevent those complications. A lot of effort went on, nothing was found out about the PKC inhibition. Then, since it was known that antioxidants play an important role in this, they thought, let's try antioxidants. Now, no one knew how much antioxidant and what antioxidant, so they carried on and died of own. Now, then they thought that if this is the case, where the oxidative stress is the part which is responsible, then let's try something which is activating the PKC, and that was oxidative stress, which was due to glycemic variability. Then the team decided that if we control the glycemic variability, probably we can win over the. So this is how the glycemic variability came forward, and now after around 15 years or so, they have won over the topic that glycemic variability is responsible for causing complications by activating the PKC. So don't worry about PKC, look at the glycemic variability. And then of course a lot of information has been went on. Some information like this was already present, that different glycemic swings giving fasting, PP, blood glucose same, but still the A1C was on the higher side, and this led on to aggravation of atherosclerosis. Now this is the information which was again available, that there are two types of HbA1c. One is a good A1C where the variability is minimum, like red one, and second is bad A1C where like the yellow one. The mean is okay, but the complication rate in this is much more. So let's select the HbA1c of good type, and this is responsible for a better outcome rather than poor outcome. Now a key review about this particular concept of variability. Now it shows that to key metric to support the effective diabetes management, now there are three factors. One of course is HbA1c, but we have found the negative part of HbA1c, that it could be bad A1C as well as new A1C. Two more factors were attached to this. One is glycemic variability, that if you want to have good glycemic control, then in that case you have to cut down the variability and maintain a minimum possible variability. And third is, which is the latest, and that is TIR, that means time in range. Now with the free availability of CGMS, so this has been found out and now become pretty common, that in case you are controlling your glucose to prevent complications, you must cut down on time in range as much as possible, so that the time in range is maximum and variability is minimum. And then of course the A1C which is coming with this is a good A1C. So the suboptimal TIR can lead to microvascular complications and the mortality. So A1C where GV is minimum, where TIR is maximum, they will give the good results. Now this one Glargine 300 has got smoother PK and PD profile, allows injection time to be more flexible up to 3 hours or so, and it is non-inferior to IDEC, that means the digludec, and of course sometimes it's mixed with a short-acting insulin also. So beyond A1C, glycemic variability and TIR are also two important key parameters which help in reducing the complications of diabetes by producing minimum glycemic variability, excessive glycemic variability, and excessive glycemic variability will lead on to the complication, and suboptimal TIR, that means TIR is instead of being maximum, it is on the lower side. Thus international guidelines recommend TIR and glycemic variability as the key metrics to facilitate effective diabetes management. Now again here is CGM, all of you have seen and probably done it also. This shows that in these 4 factors are there. One is TIR, that is time in range, time above range, time beyond range, and time below is B, and glycemic variability. All these factors put together will help us in controlling the glucose in a proper way. Now this is a very important and informative slide. which was given in 2019 on for different parameters. So one is for type 1 and type 2, and here it is less than 25% of time in range is 25% and 70%. So that means it boils down to around 95%. So if you see the top, the orange one and the red one, red one, they are comparatively much smaller. So the main focus is on target in the range and target above range. So we should try to maintain target in range 70% or more than that. Next is older and higher risk individuals. In this case, if you again put together 50% and 50%, it's almost close to 100%. So that means if a person is older or high risk group, avoid hypoglycemia at every cost, and no point controlling it very tightly so that there is no hypoglycemia, and hypoglycemia must be prevented at every level, every cost. Pregnancy, most important component of glycemic control, and comparatively much different and stricter also. Here it shows that 70 within range, 25% less than this is the upper one, and then of course less than 4 or 1% the tight glycemic control towards hypoglycemia. Pregnancy and gestational type 2 diabetes. First of all, pregnancy with type 1 diabetes, this one is pregnancy with gestational diabetes in type 2 individual. Again here the green line is on the top of that, and thus one must maintain target TIR target in the range up to the tune of around 70% or 80%, and as far as the top above concerned, it is not more than 2 or 3%, and thus maintaining such graphs. And in fact, a copy of these graphs can be kept at the table, your prescription table, so that instead of cramming them, you use them as and when a new patient comes. Now, suboptimal TIR can have a substantial negative impact. Now, 10% drop in TIR, that means the control has become poorer, and there is drop in 10% drop in the TIR. It is this is associated with 64% increase in the retinopathy. That means other complications are also getting affected, like retinopathy is there, then nephropathy, all those things they come into picture. And then 25% increase risk of peripheral retinopathy. So that if your TIR drops by 10%, 64% of retinopathy chances and 25% of neuropathy chances, they start increasing. Increased risk of microalbuminuria, yes, of course it occurs if the retinopathy or neuropathy are present, and there is increased mortality in these individuals. Now it's a comparison of GLA 300, the so-called and the first generation basal insulin. So this is the comparison with the Lantus. Now this is a study which is trying to trying to assess the coefficient of variation. This blue one is Glargine. This is the Glargine blue one, and the green one is the Tudio, or for that matter Glargine 300. Now you see that there is the coefficient of variation is very minimal somewhere in the middle, otherwise they have been overlapping each other. Again, GLA 300 allows flexibility, as I mentioned earlier, up to 3 hours. So within 3 hours, a repeat injection can be taken. Other parameters have been mentioned over here. And GLA 300 demonstrates a lower function, nocturnal hypoglycemia. Now this is something which is important. Hypoglycemia occurring when the patient is sleeping. That is most dangerous, because the patient may not be able to appreciate the symptoms or signs which are there, and that lapse into a deeper part of hypoglycemia. So nocturnal hypoglycemia between nights was numerically lower with GLA 300 as compared to IDEC. Then of course summary of multiple studies. Now here Glargine U300 trials using CGMS. Now again, as you see the previous one, this if you look at this slide and you look at this one, they are almost similar. That in the middle of the day, there is coefficient of variation is slightly on the maximum side, but overall they are matching with each other. Further data demonstrating lower variability with GLA 300 is of course well mentioned over here, that they are almost these two lines. This is GLA 300 and this is this is IDEC and this is GLA 300. So comparatively coefficient of variation remains almost similar as in the previous one. Flash glucometer monitoring, again something similar, and percentage of time in nocturnal hypoglycemia with the GLA 300 was significantly lower as compared to the IDEC. Again CGM study in type 2 diabetes comparing time in range and GLA 300 versus Digludec. So again the summary is that if you look at the results are almost same, matching well each other. So there is hardly any difference between TIR of GLS 300 versus IDEC 100. Again flash glucose monitoring of TIR of GLA 300 versus Digludec, again quite similar to each other, overlapping the main thing. Then one care study, real world study in adults with type 1 diabetes using CGM GLA versus this 300. Now it shows that almost same results are there. They are different but significantly no significance is there. Basal plus versus Digludec. So that means along with the GLA 300 they have added the bolus of short acting insulin versus this Digludec as part, whereas single injection containing both long acting as well as single shot of short acting as part is there. And then again the GLA 300 basal plus demonstrated in this study TAR was increased comparatively, hypoglycemia was decreased by 7 times and nocturnal hypoglycemia reduced by 18%. Though it is 18.7 and on the higher side, but statistically they were not significant. Again probably the last study in range GLA 300 versus IDEC 100 in type 1 patients, and here again the primary endpoint was the TR more than 70% and upper limit was less than 180, and glucose total coefficient of variation at 12 weeks was almost similar. Now in range study primary and secondary endpoints, this again they are almost similar, primary endpoints, secondary endpoints not statistically significant. And now finally coming to the last slide, in range study. In range is again something which is important. The first RCT comparing GLA 300 versus Digludec 100 in the patient with type 1 diabetes. Primary endpoint well met, secondary endpoint almost met, and hypoglycemia safety they were slightly better in GLA 300 as compared to IDEC. Because of IDEC there was some suspicion that short acting insulin may cause a little bit of hypoglycemia. So thus the GLA 300 is a non-inferior study as compared to GLA 100. So sum up, glycemic variability and sub-TIR can significantly impact the lives. So time has changed when we are going to look at the glucose monitoring along with the HbA1c, which can be of bad type, and thus improve upon through the CGMS, and things are going to be much better, complications are going to be much less. GLA 300 allows dosing flexibility, 3 hours 1 plus as I mentioned. Numerous trials are going on with the CGM and TIR, and ultimate aim is to minimize the flexibility and thus try to cut down the complications, and then the quality of life is going to be much better. In fact, these days people are talking about diabetes reversibility also, and this is truth. Though it may be remission or reversibility, the things are moving in the correct direction, that it is possible to even prevent the complication, and also it is possible to reverse the disease if possible, if early diagnosis is made and the better type of drugs are used rather than the one which the so-called secretagogues, etc. So the use of GLA 300 is associated with lower incidence of overall nocturnal hypoglycemia. This is the probably most important one versus Glargine 100 and Digludec 100. So ultimate aim number one rather is to prevent hypoglycemia at any cost. After that it comes the good control of glucose, and by reducing hypoglycemia the variability obviously will come down quite a bit. So with that I end my talk by saying that these new drugs have taught us one thing, that controlling glucose is not important. How to control glucose, that is probably much more important. So that variability, etc. And the best teachers are those who show us where to look, they don't tell us what to see. So one has to take the patient into consideration and then accordingly take decision in the patient. A patient who is rich can definitely afford so many things, and patient who is a poor, one has to manage whatever is possible. Thank you so much.
Thank you so much, sir, for the wonderful talk. And we've learned two most important things, that we have to keep the sugars within range, that is time in range, and to avoid nocturnal hypoglycemias. Thank you so much, sir. So to keep the discussion moving forward, so I owe a pleasure to call a great friend, Dr. Shalini Jaggi, for the next session, for the next talk. Dr. Shalini needs no introduction. She's a director CMRE and extensively working as a diabetologist.
Slide set. Good afternoon, everyone. Just give us a minute, please. Thank you so much for being here. कहाँ है मेरा slide set? मैंने अपलोड करवाया था ना? ये नहीं है।
एक सेकंड रुकिए।
So good afternoon, everyone. Sorry for that glitch. I think technology sometimes does make those things happen. So okay. So the task assigned to me today is to talk on basal insulin optimization and how we can move closer to our glycemic control by optimizing basal insulin. Now the problem with insulin is not only patient acceptance, that we all think patient will not accept, but sometimes the patient does accept, but we fail. How do we fail? The simple answer is the paradox, because we tell the patient to take the injection, but we do not tell him how to titrate the doses and keep titrating them till he reaches the goal. So the whole idea of starting insulin gets lost if he is taking insulin injections but not optimizing his insulin dosages. So what I am going to talk about is the insulin paradox. Are we actually initiating insulin but still failing because we're not really titrating and optimizing the dose? And then we'll talk about the unmet need of the hypoglycemia risk and weight gain with basal insulin. And then we'll talk on simple insulin intensification strategies, how in a very simple stepwise manner we can progress towards achieving a good glycemic control. It's okay. So what exactly?
This is not duplicates right now.
What's happening? Chalo, it's okay, I'll manage. Okay. So, ठीक है, चलने दो. It's okay, I'll manage. The problem is we do talk of insulinization. We understand that type 2 diabetes is a progressive disease. And as diabetes progresses and glycemic control worsens, there is an increase in association with complications and comorbidities, and therefore a majority of patients with type 2 diabetes over a certain period of time will eventually need insulin for better glycemic control. But the problem is there are a lot of studies which have clearly shown that despite initiating insulin, taking those insulin injections religiously, I'm not talking of patients who stop insulin, who do not take insulin, there will be that section of patients who will listen to you and take insulin shots just as you have explained, but still glycemic control is not routinely achieved. Data clearly shows that almost 85.9% of patients with type 2 diabetes who are on insulin and OADs, and out of them 79.3% of these patients are not on target. So even if they are on insulin alone or insulin plus OADs, almost more than 80 to 85% patients, in spite of taking those insulin injections, are not on target. Now this brings into perspective what is called the titration period. So you've initiated insulin, titration period is about 12 weeks, the first 12 weeks of insulin therapy that your patient is taking, and there is data which shows that titration period predicts long-term outcomes when it comes to the patients with diabetes. So if you are able to titrate well, in the maintenance period the long-term outcomes are going to be better. More than 80% of the maximum treatment effect, that means the HbA1c reduction that we are talking of, occurs in the first 12 weeks of initiation of insulin, and early response predicts the long-term glycemic control, and the HbA1c that you are able to achieve in that first 12 weeks, that actually can be maintained up to 24 months if your patient is religiously doing SMBG and fine-tuning his insulin doses, and I'll come to that in a little while. Furthermore, we now know that early hypoglycemia doubles the risk of future hypoglycemic events, and early hypoglycemia also increases the risk of treatment discontinuation. So when we are starting insulin, what do we need to do? Of course, the whole idea of starting insulin is to get the patient on goal, and that is why titration is required. But you want to do that minus the adverse effects, minus those query cautions, which means hypoglycemia and weight gain. Now, a good key to successfully managing glycemic control, therefore, is adequate titration. So by definition, like I said, titration period means that first 12 weeks following the initiation of insulin or switching to basal insulin, in clinical trials, when you've started insulin, and in the next 12 weeks you are going to ask your patient to titrate his insulin doses till he reaches goal. 30 to 50% of patients still remain uncontrolled 6 months after basal insulin initiation, and the main culprit for this is inadequate titration, because we tell him how to take insulin, we give him a dose, start 10 units, and the poor patient goes home, keeps taking those 10 units for months on end, sugars are still not on control, because we forgot to explain the importance of titration. And that is why we say even that patient is on insulin, still the statistics are showing glycemic control is not achieved. Now this is the difference that the first 12 weeks can make in a patient who is initiated and titrated well. You can clearly see here for a baseline dose of 0.16 at initiation with an HbA1c of 8.8 and a fasting plasma glucose of 195, you clearly see how if you are able to adequately titrate, not only do you get a 1.4% reduction in HbA1c, and what does a titration means? You keep increasing the doses till the goal is achieved. So almost 150% increase in insulin dose compared to the initiation dose may be required to finally get the fasting down and achieve an HbA1c. And then following that, in the next 12 weeks of maintenance period, you can see that if your patient gets into that habit of SMBG and reacting to it in terms of adequate titration, you will still achieve benefits, but obviously beyond that you hardly need a small dose increment. So fine tuning could be another 12.5% increase in dose and an added HbA1c reduction of 0.2%. So friends, early initiation and adequate titration is the mantra for optimal glycemic control. This is clearly shown in this data, showing how initiation of glargine U100 with OADs, if titrated well, can help your patients achieve a sustained glycemic control for as long as more than 2.5 years. So you can see here, HbA1c at initiation 8.7% with 14.2 units of insulin that was initiated and eventually titrated to achieve a glycemic HbA1c target of 7.2. Beyond this, patient is still able to fine-tune the doses to achieve an HbA1c of 7 and maintain it at 7 with a slight fine-tuning. So from 14.2 to 20.2 and then 22 and 23. So in the first 12 weeks, you need maximum dose increment. Beyond that, in the maintenance, you hardly need another 12% increment in doses to actually fine-tune and get the magic numbers, the magic glycemic goals that you've set for your patient. Now, putting in perspective hypoglycemia risk and weight gain with basal insulin, You can clearly see here when you compare the basal insulin, glargine 100 versus the co-formulation or the premix insulins, clearly you will see much less weight gain, much less confirmed hypoglycemia, be it overall hypoglycemia or nocturnal hypoglycemia, obviously because in a premix insulin or a co-formulation, the aspartate is a much more potent component and it can drive that patient to hypoglycemia, and dose titration becomes difficult in a premix or a co-formulation. Compared to that, in a basal, you know you are targeting a fasting, so actually the dose titration becomes much easier. Now again, this study translates into the fact that when you compare glargine 100 to Bias 30 or even Ideg-Aspart, you can see a 35% less weight gain with glargine in comparison to Bias 30, and again a 36% less weight gain with glargine U100 compared to the co-formulation of Ideg-Aspart. So when should we consider insulin intensification in your patient with type 2 diabetes? I am not talking of initiation, I am talking of intensification. Obviously, we know that there is a decline in first phase insulin secretion post meals leading to postprandial hyperglycemia. And we know postprandial hyperglycemia is directly linked to overall glycemic exposure and the complications. Now, why we need to keep postprandial hyperglycemia in mind is because sometimes even if the fasting is on target, the HbA1c is still not on goal. There, the hidden contributor could be postprandial spikes. We know that postprandial hyperglycemia generates oxidative stress, leading to endothelial dysfunction, inflammation, and all the different complications associated with type 2 diabetes, including cardiovascular disease. So therefore, you cannot ignore postprandial hyperglycemia, and this is where if you've initiated a basal insulin, HbA1c is still not on target, but the patient is on good fasting plasma glucose control, you need to do something to get the postprandials also down. Now, what is the best way of intensification when your patient is on basal insulin? Of course, adding a prandial insulin, which is very simple, almost mimicking physiology. So obviously that is how our pancreas are making insulin. There's a basal secretion that happens all the time, and then in response to a meal, you always get those prandial spikes in insulin secretion in the body. And this is what we try to mimic. When your patient is not controlled on basal, you add a shot of the prandial, exactly mimicking normal physiology and helping you get the postprandials on target. Now, basal insulin is going to suppress the glucose production by the liver between meal times and overnight when your patient is not eating, and the prandial component is going to take care of the postprandial glycemic surges. So what is the advantage of the basal prandial intensification? Of course, the postprandial excursions will come down, fewer hypoglycemic episodes and lower weight gain. The dose titration is very, very easy. So you know, fasting is not on control, you keep titrating the basal. Whichever pre-meal is not on control, so whichever post-meal glucose is not on control, so the pre-prandial shot you keep up titrating. So it is a relatively simpler regime, more user friendly, and in a stepwise manner you can titrate the doses. So what is the basal concept and the basal plus or the basal bolus insulin concept? Basal insulin concept means your patient is failing on oral anti-diabetic drugs. You start with a small dose of basal insulin, maybe 0.2 to 0.3 units per kilogram based on the patient's HbA1c, and then till the fasting plasma glucose target is achieved, you can keep increasing 2 units every 2 to 3 days till the fasting goal is met. That's the basal insulin concept. Now, basal plus or the basal bolus insulin means there are two components. There's a basal component, which is the baseline, the foundation of your insulin therapy. So that's the constant background level. About 40 to 50% of the total daily need is the basal insulin. And remaining is the bolus or the prandial shot, which means the meal induced spike. So this is about 10 to 20% at each meal. So before each meal you divide the dose into 10 to 20%. So that's the prandial component. That's how you use a basal bolus regime. So when I talk about intensifying the basal insulin therapy, the two options are, of course, your patient is already on basal. He's reached his fasting plasma glucose target. HbA1c is not on control. What do? Two options. You stop the basal, you shift him to a premix insulin twice a day. Or you continue with the basal because fasting has already been achieved and you add a prandial shot to take care of the prandial dose. So basically what you do is, suppose the lunch is the reason behind the spike here, all you do is a preprandial shot given at lunchtime to bring down that spike and get the glucose levels on control. So when it comes to intensifying the insulin therapy, what is the difference between basal plus versus a premix? So there also it is 2 shots, here also it is 2 shots. What is the difference? When you're using a basal plus, there's more flexibility, because the basal prandial is favorable for patients who have irregular meal patterns. So one day maybe he's having a heavy breakfast, the other day he's skipping his breakfast, he's having a heavy lunch. So what you can do is you can give the prandial shot with lunch. Maybe some other day if he's not going to have a heavy breakfast or a lunch and having a heavy dinner, so the prandial can be given at that time. You do not get that kind of a flexibility with a premix. So the basal can be given once a day and the prandial can be given with whichever is the biggest meal of the day, giving your patient a lot of flexibility. Compared to that, when you have a premix insulin, of course, if you increase the doses, it's going to work, the long acting component is active for 12 hours. So obviously an increased rate of hypoglycemia, an increased dose requirement, and therefore more weight gain also. So compared to, it is, the premix is not really very, very flexible compared to a basal plus a prandial regime. Now this is data clearly showing how when you compare glargine 100 intensification to premix insulins, you can clearly see the nocturnal hypoglycemias are much less, in spite of the fact that this is the arm of patients who are actually achieving the HbA1c less than 7%. So in spite of getting better HbA1c reduction, they are getting it at much less hypoglycemia, clearly telling you that basal definitely works better compared to a premix when it comes to achieving your fasting plasma reduction and an HbA1c goal. So when it comes to the bolus insulins, what are the 2 choices we have? Of course, on the one side we have the conventional regular human insulins, and of course now we have the analogs or the rapid acting insulins. What is the difference between them? Just a very quick recap. We know that the regular insulins have a very slower onset of action and they are little longer acting compared to the rapid acting, which has a quick in, quick out kind of an action. So the moment you inject, it starts working very fast and then it's out also very fast. Therefore, not only is it better in controlling the postprandial hyperglycemia, but also it has a much better mealtime compatibility. Because with a regular insulin, normally we tell the patient to take the shot and wait for 10 to 15 minutes or 20 minutes before actually having their meal. So therefore, with the rapid acting, you have the flexibility. It can be taken just before the meal, even up to 15 to 20 minutes after starting the meal. So it gives you that window period. He can finish his meal and still take the shot. It is going to work exactly the same way, and has much less glycemic variability and definitely much less postprandial hypoglycemia. Salient features of adding a glulisine to basal insulin, like I told you, the dosing window is quite good. So 15 minutes before and 15 minutes after, you can dose it at that time. Total daily dose comes down because obviously you can titrate exactly based on the meals, provides a more consistent rapid acting profile across the ranges of BMI and skin thickness when compared to Lispro. Glulisine has faster onset of action compared to Aspart, quick in, quick out like I said, and the time of administration, like I said, you have that window of 35 minutes. Now intensification recommendations, when do you stop titrating basal insulin? If your patient is already on 50% of his body weight dose of basal insulin and glucose levels are not on target, it is time to either stop the basal or to up titrate and add a bolus. So you can intensify with the prandial insulin, maybe 1 dose with the largest meal, and then add the second or the third depending on whichever is the heavier meal. And like I said, simple initiation for the bolus, you can start with 4 units and then based on the SMBG you can keep increasing till the postprandial spikes are taken care of. So basal plus and IDEG Aspart, we all think co-formulation is very expensive. Basal plus can again be more expensive than that. So if you actually compare the cost of using 2 insulins versus 1 insulin. So co-formulation on one side and glargine plus glulisine combination on the other side, clearly you can see that basal plus can be an effective alternative to a co-formulation intensification approach, especially in terms of better safety, flexibility and cost as well. So friendly for the pocket. So friends, my key takeaways: basal insulin is recommended as the most convenient initial insulin regime and can be added to metformin and other oral agents if your patient is not on target. Even at high A1C, that means more than 9.5%, we know that glargine 100 is well tolerated even in insulin naive patients with diabetes, type 2 diabetes with a low risk of hypoglycemia and weight gain. Over the course of time, we know this is the gold standard basal insulin, the glargine U100 in patients with type 2 diabetes. There is 86% higher rate of overall confirmed hypoglycemia with idegespat compared to the glargine 100 in patients with type 2 diabetes who are inadequately controlled on basal insulin. Titration period, the first 12 weeks that you initiate and then titrate the doses actually predicts the long-term outcomes in the maintenance period. So a good titration period with no hypoglycemia motivates your patient to continue the insulin to maintain good glycemic control, and therefore intensification with glargine 100 is associated with a lower risk of nocturnal hypoglycemia compared to the premix insulins. Thank you.
Thank you, Dr. Shalini, for an excellent presentation. I would like to request you to join on stage. Yeah. Any questions? Dr. Surendra Kumar is not here at the moment. No. No.
So maybe we can take one or two quick questions before we go to the next. Mike.
Excellent talks, both of you. My question was to Dr. Surendra Kumar. Very nicely explained the effect of glycemic variability on the outcome. So, and glycemic variability with hypo is even worse, especially for elderly. So, what is the level when we call hypo? But there was some confusion.
A patient who is getting symptoms of hypoglycemia, the nervous or the autonomic symptoms, sweating, palpitations, shakiness, feeling drowsy, you check his glucose levels. If it is dipping less than 70, we call it hypoglycemia. That's the typical definition of hypoglycemia. And severe hypoglycemia means when it is going less than 54, and usually in severe hypoglycemia, patient needs third-party assistance.
Corollary to my question is the target in range for pregnant and the...
I am going to do a session on time in range, sir, around 4:30 in the other hall.
The range there was 63 to 140.
Yes, because in pregnancy...
Is the hypoglycemia range different?
No. Pregnancy is a very different physiological state, sir. Because of the diabetogenic stress of the pregnancy hormones, that is why the glucose levels are already pushed up. And the other thing is that in pregnancy, the glycogen stores will not let the hypoglycemia happen. So it's very unlikely that the lady gets symptoms even at the normal levels in the non-pregnant levels. So in pregnancy, the ranges are different because the maternal shift of metabolic fuel from the mother to baby is happening. So therefore, the definition, the targets in pregnancy are also completely different. So 63 is not a hypoglycemia in a pregnant woman.
That was one of my questions. Yes. So in your talk, it was very well presented, ma'am, and there was, I can say, there is a legacy effect of initial 12 weeks, which carries on. If you control it better, the results will be much better. Thank you so much.
Thank you, sir.
I would now like to request our chairpersons to hand over the memento to our speaker, Dr. Jaggi. Chairpersons ko. I request Dr. Meena Chabra ma'am to please present the memento to the chairperson. And from the chairpersons to Dr. Shalini Jaggi. Indeed, the symposium brings the finest minds in the field of diabetes research, treatment and care. Let's move on to our next symposium, which is the Care Me Symposium. I would like to call upon stage to chair the symposium Dr. Rakesh Gupta and Dr. Harpreet Singh. Dr. Rakesh Gupta is the Senior Consultant Physician and Diabetologist at Sarvodaya Hospital, Faridabad. And Dr. Harpreet Singh, the Senior Consultant and Head Medicine Department at Kainos Hospital, Rohtak. Thank you, sir.
Good evening all, and thank you the organizers for having invited me as a chairperson. My co-chairperson had to go somewhere. He just informed me on that. In this part of the lectures, we have a very interesting topic, cardiorenal metabolic remissions in early diabetes. And I invite Dr. Meena Chhabra from Delhi. She is a senior visiting consultant, diabetologist at Sir Gangaram Hospital. And she has been chairman of the Delhi chapter, a Woman and Diabetologist Award from the RSSDI, and many other honor awards, including Dr. B.D. Kumar Oration Award. I invite Dr. Chhabra to please start.
Thank you for the kind introduction. So I have a very interesting lecture today which talks about not just remission of diabetes, but it talks about cardiorenal metabolic remission. And doctors, I'm proud to say that we are achieving metabolic remission in our patients now. So why do we have an increased risk? The reason is that if you see extreme left, we have low birth weight because of maternal malnutrition. Now this low birth weight baby is leaner, has greater fat mass, and when this baby starts eating food, there is a catch-up growth, and this baby in utero is not used to lot of food. So what does this baby do? It cannot handle the food. So that is why we say that we Indians are a starving population, and what we do is we tend to store fat. We imagine a famine and we tend to store fat, so we are thin fat Indians, and we have this Indian phenotype. There is an intergenerational cycle of high risk phenotype, and this leads to diabetes at a much lower body mass index, cardiovascular disease at a much younger age, and chronic kidney disease at a much younger age. So this is very distressing. And why does this happen? And what can we do to address the risk? My slides, give me 1 minute, my slides are not moving. Yeah, they are. So this is a very interesting trial done in India. It's called the SINDI-2 study. Now what did they do in the SINDI-2? This was Dr. Sosale and his group. He found out that all type 2 diabetic patients recently diagnosed, and they tried to see if they had risk factors like hypertension, smoking, overweight, obesity, and dyslipidemia. And they found that in the age group of 21 to 30 years, 15% newly diagnosed patients were smokers, 13% had hypertension, 22% were overweight, 56% were obese, and 62% had a high LDL. So this is very interesting, and this prompts us to take care of our patients who come to our clinics, even newly diagnosed type 2s who come to our clinic. The first step all of us should do is calculate the eGFR, and the next step is to calculate the ASCVD risk. Now, what is the driver for such increase in cardiometabolic risk? Insulin resistance. And what does insulin resistance do? We know there is resistance at the level of the liver, the muscle, and the adipose tissue. So when there is insulin resistance, there is increase in the adipocyte cytokine formation, there is weight gain, dyslipidemia, hypertension. All this leads to impaired glucose tolerance, impaired fasting glucose, and early diabetes. Now, friends, risk of subclinical atherosclerosis starts rising even in pre-diabetes. This is a very interesting trial, and this is called the PISA study, PESA, where they checked the coronary artery calcium score by a CT, and they also did the carotid intima media thickness by ultrasound, and even iliac and femoral artery thickness, and they tried to look for narrowing of the lumen and the clots. So they found it was so interesting that even in patients who were not yet diabetic but had a level of HbA1c more than the others. For example, if you see, as the HbA1c rises from 4.8 to 6.1, the coronary artery calcium score increases, which means that any level of HbA1c, once it starts rising from 4.8, increases risk of atherosclerosis, and atherosclerosis might start rising even in the patient who is not yet even pre-diabetic. So this is very interesting. So look at the carotid arteries, the carotid intima media thickness. Again, as the HbA1c rises, the carotid intima media thickness increases. So again, risk for cardiovascular events starts rising even before onset of diabetes. There was a 3.6-fold increase in risk of MI or stroke in a 10-year period prior to diagnosis of type 2 diabetes. And doctors, you will see such patients who had bypass surgeries and they come back to you after 7 to 8 years, now they have developed diabetes. So this again, Nurses Health Study proved that 15 years before the diagnosis of diabetes, the increase in risk of MI is 2.40, 10 to 15 years before diagnosis, it is rising, and less than 10 years before a diagnosis, it is rising further. Insulin resistance leads to myocardial metabolic dysregulation, poor energy efficiency, there is oxidative stress and early diastolic dysfunction, and we know when you get echocardiograms or 2D echocardiographies of obese patients, you will see in almost 45 to 50% patients evidence of left ventricular diastolic dysfunction. That means there is difficulty in relaxation. So markers of subclinical cardiac disease starts increasing from pre-diabetes stage. Again, you will see no diabetes versus pre-diabetes versus diabetes. CTNT is the troponin, rises when the patient is diabetic. CRP rises, NT-proBNP rises, the LV ejection fraction decreases, the GLS, this is another marker on 2D echocardiography, and the E by E another marker. All these markers are starting to rise even in pre-diabetes. So this again proves that we need to address our patient of metabolic syndrome. We need to address obesity. We don't want them to become type 2 diabetics, but not just glucocentric. Not that we don't want to become diabetics. Even the incidence of heart failure is more in the obese. The incidence of dyslipidemia is more in the obese. The incidence of MI and stroke is more in the obese. So we have to target our metabolic syndromes more aggressively, which we are not doing. We tend to actually dismiss the obese without diabetes and hypertension, which we should not be doing, and address them. Diabetic cardiomyopathy occurs early and progresses with time. You can see this. Nearly 1 out of 2 people with diabetes have diastolic dysfunction. This is a meta-analysis of 27 echocardiographic based studies. Progression of diabetic kidney disease by duration of diabetes. As the duration of diabetes increases, you see DKD, diabetic kidney disease, goes from the stage of hyperfiltration to the stage of silent diabetic nephropathy to stage 2, 3 and 4, 5, which means the importance of doing the albumin creatinine ratios in all our patients of type 2 diabetes. It's very important that the take home message is look for target organ damage, look for albumin. It's a simple test, urine albumin creatinine ratio, and it will give you evidence of endothelial dysfunction. Start doing it in all your patients, albumin creatinine ratio. Now peripheral pulses, so easy to check. We must do it. We must have the habit of checking the dorsalis pedis as well as the posterior tibial, a very simple test. Just tell the patient to remove the stocks and do it. See, compared to a patient who has no absent pulse and a patient who has 1 or 2 absent pulses to a patient who has 3 or 4 absent pulses, because we are seeing 2 dorsalis pedis both sides and 2 posterior tibial, just look at the risk of major macrovascular events. Just palpating can give, your antenna will be up that you need to address this patient with multiple therapies. You need to control the blood pressure, the dyslipidemia, the blood sugar better. You have to add your advice and tell the patient to quit smoking. And if the patient has a very high risk of sudden death in first degree relatives, which could be a parent or a child or a sibling, you have to aggressively do coronary angiographies or other tests, stress echoes, to rule out coronary artery disease. So again, the message is we should not miss atherosclerotic cardiovascular disease in our patients, and we should not miss early heart failure in our patients. Now, autonomic neuropathy, vascular complications in people with newly diagnosed type 2 diabetes, even in the UK PDS, those who were newly diagnosed, the clock was already ticking. They already had evidence of microproteinuria, evidence of macroproteinuria, which means either they were, for a while they were obese, then they went into impaired glucose tolerance or impaired fasting glucose, and then they became type 2 diabetics. So there is a continuum, a risk continuum from being a patient of metabolic syndrome to being a pre-diabetic and being a diabetic. Now, this is, I'm a part of the YDRS, so we are registering young type 2 as well as type 1 diabetics, anybody who's been diagnosed with diabetes at age less than 25 years. And we found, compared to the SINDI-2 trial, in the SINDI-2, which is I told you Dr. Soslay's study, the newly onset type 2 diabetics, they quantified the risk of, they quantified the complications. We are doing the same. So in SINDI-2, neuropathy in 13.2% patients at the onset of type 2 diabetes. Today my patient has come to my clinic and he is newly diagnosed type 2 and already has neuropathy. 5% have retinopathy, 0.93 had nephropathy, 0.6 had ischemic heart disease, 2% had peripheral vascular disease, and 0.13 had cerebrovascular disease. Now, why is SINDI-2 different from YDRS, of which I am a part? Because YDRS we have considered people young, 25 years, and still you see retinopathy in 26% patients, also proving that the younger diabetic needs very aggressive management, and so much so that the young type 2 diabetics are now called malignant type 2 diabetics. So here comes the importance of not treating every patient similarly. Patients need different treatments. We need more aggressive management with newer drugs with pleiotropic benefits, and day after day I see prescriptions of only sulfonylurea and metformin doctors. We must change our practice. We must remember to calculate the ASCVD risk, whatever risk engine you may use. We have the score 2 now, and this again ESC says, ESC has changed its guidelines in cardiovascular disease, and it says that if your patient has mild cardiovascular disease, moderate risk of cardiovascular disease, or very high risk, you should actually subgroup them first. If the patient has a very mild risk of developing cardiovascular disease in the next 10 years, you may continue with metformin. But if the patient has moderate, high risk or very high risk, you have to give drugs with pleiotropic benefits, which means you have to start the SGLT2 inhibitors, and you have to, or with GLP-1 RA. I will agree with my colleagues that GLP-1 RA may be difficult to start in the Indian patients because of cost, because of other issues of tolerance. But yes, nothing should stop us from using SGLT2 inhibitors if the cardiovascular risk, ASCVD risk, is high in our patient. And ESC, the European Society of Cardiology, actually tells us that you should be doing this. So see the cardiovascular risk categories. They use the score 2. This is available on your mobile phones. And if the score 2 says that the patient will develop ASCVD and in the next 10 years and the risk is very high means there's a more than 20% chance of developing ASCVD. So you divide the patient 10 to 20%, 5 to 10 and less than 5. Only if the risk is less than 5%, you are justified in using metformin alone. Otherwise, you should start with a drug with pleiotropic benefits like SGLT2 inhibitors, because trial after trial has demonstrated that you could address cardiovascular risk, of course with or without GLP-1 RA, because these drugs can address CKD progression as well as ASCVD risk. Now again I talk about holistic cardiorenal metabolic risk management. You can prevent, you can regress also, and you can retard. And we've seen regression. I've seen regression of proteinuria in my patients on SGLT2 inhibitor and definitely seen regression in carotid intima media thickness on patients with GLP-1 RA. So value of early multifactorial control is well recognized in the Steno 2. And this is the holistic person-centered approach. I'll just take 2 more minutes. The bell rings 3 minutes before. So this is the holistic person-centered approach. Again, we are talking about, precision and personalized care. So if a type 2 diabetic is young, You have calculated the ASCVD risk and it is very high because he has hypertension, he has dyslipidemia, he has obesity, he has a history of smoking, he has family history of coronary artery disease or family history of stroke. His ASCVD risk is high. You should not just have a glucocentric approach but a metabolic approach where you must control not just the glucose but the lipids as well as the blood pressure. Motivate him to quit smoking and start drugs like SGLT2 inhibitors or GLP-1RA which would address the risk. And so use of glucose lowering medications in the management of type 2 diabetes, again metformin still remains on top. We are not telling you to stop writing metformin, but yes, we are saying that you have to be aggressive in managing the and we are seeing very malignant type 2s. I have seen a young patient, a girl who developed type 2 at the age of 22 and at 29 she has come with cardiomyopathy. So we know that these things can happen and that is why we should aggressively address risk factors. So this is the multifaceted intervention, improves adherence and outcomes. This was the coordinate trial. And to summarize, I'll say that Indian people with type 2 diabetes have increased cardiorenal metabolic risk which begins at a much younger age. So it's our duty as a clinician to talk about reversal, not of just the numbers, not just reversing diabetes or remission of diabetes, but it's our aim to talk about reversal or remission of the atherosclerotic cardiovascular disease risk and the risk to the kidneys. So it is possible to prevent the occurrence of diseases and complications with early and intensive multifactorial control. So my take home message to all my colleagues is, again I repeat, doctors, don't forget the ABC, the A1C, the blood pressure and the cholesterol. Don't forget to counsel the patient on quitting smoking. Kindly use any risk engine available on your phone or just use your your sixth sense to calculate the ASCVD risk, and if the risk is high, please make sure you do the 2D echo, you do the stress echoes, you do the coronary angiograms, and you aggressively address the risk by giving drugs like GLP-1RAs, whether orally or injectably, and to give the SGLT2 inhibitors to the patient so that you help the patient lose weight. So that's the gist of my talk. And beyond control of glycemia, personalized approach for kidney protection and cardiac protection is what our job is. Thank you.
Thank you, Dr. Chabra. The one-liner, if it has to be spoken, she speaks that beyond the blood sugar levels, the other blood pressure, cholesterol, as has been the discussion, and maybe it's the HDL which should be followed. But more importantly, the kidney and heart needs regular screening in the early part of it. Thank you, Dr. Chabra. Now I invite this next speaker, Dr. Abhay Aluwalia. He takes us for early CKD management is essential in type 2 diabetes. Dr. Abhay is a surgeon captain in the Indian Navy. He's retired. He is DM endocrinology, presently professor of medicine and endocrinology, has publications and has been the recipient of DP Basu Award, Young Scientist, that was way back in 2004, a DSL Award for Best Paper by SECON in 2004, a graduate silver medalist from Pune University, and KK Gupta Gold Medal for his MD course at FMC Pune. I invite Dr. Abhay for the deliberations.
Thank you, organizers, and thank you, Chairman, sir, for the kind words. My role today is early CKD management is essential in type 2 diabetes. My job is made simpler by Dr. Meena Chabra by introducing few concepts in CKD management. So let's get down to what is the KDIGO definition of diagnosis of chronic kidney disease. This is an abnormality in the structure and function of the kidney, which is defined as a GFR of less than 60 ml, and presence of albuminuria, abnormalities in the urine sediment, and electrolyte abnormalities, and past history of, and all these things should be there for 3 months and over before when you start calling it CKD. American Diabetes Association calls CKD as chronic kidney disease diagnosis persistent elevation of urinary albumin excretion and a low estimated glomerular filtration rate and other manifestations of kidney disease. So the definition of KDIGO and CKD of American Diabetes Association is similar, but what leads to chronic kidney disease or diabetic kidney disease as it's called now? You have hyperglycemia. What it does is it causes a change in the renal hemodynamic status. transforming growth factor beta. This results in glomerular hypertrophy. You have oxidative stress, which also contributes, and activation of renin-angiotensin-aldosterone system. Inflammation with increase in cytokines leads to podocyte injury, tubointerstitial fibrosis, and others are genetic modifications. There is podocyte autophagy. This results in inflammatory stress, and ultimately all this results in the diabetic kidney disease. If we go to the pathophysiology of diabetic kidney disease, it goes from stage 1 to stage 4. The earlier stages is thickening of the glomerular basement membrane. Then you have mesangial expansion, followed by stage 3, which is nodular sclerosis, that is Kimmelston-Wilson bodies which are there. And the stage 4 is nodular glomerulosclerosis and complete hyalinization. Unfortunately, we don't do kidney biopsies in all diabetic patients to know. So we don't know what is the underlying pathophysiology. So we come down to a case. This is what exactly happens. A 54-year-old patient with a diabetes for 5 years, dyslipidemia, hypertension. He's got a cholesterol of 180, A1C of 7. The fasting triglyceride is 120 on metformin, sitagliptin and ramipril. Really blood pressure is 135 and BMI of 30. We all would be happy with the glycemic status, but we really don't know what the renal status is. So that is two tests which are not routinely done, is estimated glomerular filtration rate and urine albumin creatinine ratio. So this, you have to develop a practice of doing this. And why is it important to know the early CKD? You have about 11% of the global population which is affected by CKD. And inside CKD study says in the next 3 to 4 years, we're going to have a 10 to 14% increase in prevalence of chronic kidney disease. And these studies have been done from all developed nations. We have our own problems with CKD. The population with CKD is about 17.2%, and out of them, more than 2 lakh patients are on dialysis, and there are about 5,000 dialysis centers all over the country, which may be on the slightly lower side. We have a greater demand of these dialysis as the population is aging. The number of patients and number of dialysis centers. So the role of prevention and identifying that CKD is important. So we come down to the KDIGO recommendation for high risk group. That means you have to identify cases. You have to find out the cases for CKD prevention, and that include hypertension, diabetes and cardiovascular disease. Along with that, obesity, older age, prior history of acute kidney injury, race, family history and genetic factors are the factors which you have to do these tests to identify. Now, early diagnosis and intervention, this is a retrospective study which came from the insurance patients, about 26,865 patients which are analyzed between 2015 and 2020. Out of these, all those patients who had a CKD diagnosis and they were given SGLT2 inhibitors or mineralocorticoid receptor or GLP-1 receptor agonists, these patients had a reduction in progression of chronic kidney disease. So if we identify the patients and treat them effectively, we will prevent the progression to chronic kidney disease. And if we have an early intervention, once you diagnose a patient in CKD stage 3, and then you introduce the intervention, you increase the disease-free or the CKD progression by 2 years. But if you diagnose it earlier, you have a 7 to 11 years improved quality of life and prevention of progression of the CKD. So we come down to the same patient again. You had a EGFR of this patient was 54, and then you come down to the KDIGO classes, the KDIGO heat map, where you divide the classes based upon the protein excretion into A1, A2 and A3. And the normal one being A2 in the range of 30 to 300 and A3 more than 300, that is frank proteinuria. And based upon the EGFR, you classify the patient from G1 to G5. The stage 3A and 3B indicates the place where the CKD diagnosis is made. And this patient who had a EGFR of 55 falls into stage 3B with a moderately high risk. So this patient does require treatment which is going to direct it towards the CKD management. If we know we manage intensive diabetes treatment, you look at the systolic blood pressure, get it below 140, diastolic blood pressure, get the A1C below 6.5, triglycerides and lipid management, use ACE inhibitors, use aspirin. So you reduce the progression of diabetic retinopathy risk by about, relative risk by about 0.44, that means almost 60% reduction, but still there's some residual risk which always remains. So what you require is some more guideline and some more directed therapy. And what is the guideline which says? KDIGO says that lifestyle modification is there, which you have to find the diet intake, you have to use the drug, you have to use the antiplatelet agent, start with physical activity, nutrition and weight loss. The first line therapy would be metformin, which is to be not initiated if the GFR is less than 30, and below 30 it has to be stopped. SGLT2 inhibitors can continue till the time the eGFR touches 20, below 20 it has to be stopped. The other drugs which you can use for glycemic are GLP-1 receptor agonists, DPP-4 inhibitors, sulfonylureas with a caution, and insulin therapy. The agents which have a proven efficacy to prevent the progression of CKD are ACE inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, and mineralocorticoid receptor agonists, that is finerenone. Now, if we look at 2022 ADA standards, which says CKD with albuminuria more than 200 milligrams per gram of use of SGLT2 inhibitor is recommended. Preferably, SGLT2 inhibitors should be the first line of drug along with the other therapies which have to be given. And if there's a evidence of CVOTs, then you can use a combination of GLP-1 receptor agonists. And if you come down to stage 3A of, that is GFR less than 70, the first line recommendation is SGLT2 inhibitors. In those patients who have cardiovascular risk, also a combination of GLP-1 receptor agonist and SGLT2 inhibitors. So both these drugs will prevent the progression of kidney as well as cardiovascular disease. Studies with ACE and ARBs have been published. They do have an improvement in microalbuminuria, but they don't have an effective role in preventing the progression of chronic kidney disease. Now, which SGLT2? We had 3 renal specific trials with the SGLT2 inhibitors. That is Credence, which was done in 2014 to 2018. Using canagliflozin, there was an improvement of about 36% in relative risk. Then you had a directed trial, that is DAPA-CKD. The improvement on primary kidney function decline improved by about 50%, and their secondary function also improved by about 50%. And recently we have the AMPA kidney trial also published, which had an improvement of about 24 to 29%. So 3 directed trials with SGLT2 inhibitors have shown improvement. The dapagliflozin results were slightly better than the others. So you had declared TIMI, that is the cardiovascular outcome trial with dapagliflozin, which showed that you had patients who were on primary prevention. 64 majority of the patients were on primary prevention where the dapagliflozin was used. The other AMPA, REG and CANVAS had predominantly secondary prevention and did improve the. So if we look at the dapagliflozin prevention trial, so you have multiple cardiovascular risk factors, you have increased risk of heart failure and chronic kidney disease, you have cardiorenal improvement. When you use it in the stage where the disease is not that is called primary prevention, and then the therapeutic window to improve these studies which have been there. So dapagliflozin improved the renal disease progression in patients with type 2 diabetes. So what was there and declared, the eGFR was 0.85 and macroalbuminuria was present in 32%. There was a 47% risk reduction in patients who were given dapagliflozin as compared to the placebo. So the renal benefit which was demonstrated by across the GFR groups in patients without established cardiovascular disease. So the composite, there was a 40% improvement in GFR and there was a decline in GFR improved. So the cardiovascular, so deterioration of albuminuria which was present from baseline. So what you have is 3 categories: normoalbuminuria to microalbuminuria. This improved. Normo to micro also was beneficial for dapagliflozin, and regression of proteinuria was demonstrated in these trials. So what happened in DAPA-CKD trial, where this was again a large trial, more than 4,000 patients, 4,300. Now these were stratified to receive either dapagliflozin or placebo. 56% of these patients had diabetes and diabetic kidney disease, the other one multiple improvements. So what was the primary composite outcome? In patients with type 2 diabetes, there was a 39% risk reduction in the primary, that is progression to microalbuminuria, progression to end-stage kidney disease, all-cause mortality, that is a secondary outcome, reduced by about 31%, and progression for hospitalization due to heart failure also reduced by about 29%. So this was, and in patients without without diabetes, the improvement was even better, that is almost 50% risk reduction. The all-cause mortality also reduced by about 48%, and composite cardiovascular and hospitalization to heart failure also reduced by 21%. So as compared to DACA CKD and EMPA kidney disease, the risk reduction in DAPA CKD was better, all-cause death was also better, and all-cause hospitalization was 21% as compared to 14% in EMPA CKD. So there are a number of renoprotective agents which have been used. Out of these agents, SGLT2, GLP-1 receptor agonists. So we have exenatide, you have dulaglutide, which has shown beneficial effect in Rewind study. You have semaglutide, where the studies are still ongoing on renal protection. Then you have SGLT2, which has shown much better as compared to the other agents, that is Cana, EMPA and dapagliflozin. So all these agents do prevent the progression of renal disease. So again, we talk about the number of dapagliflozin which are available. So the original dapagliflozin certainly has a better bioavailability, and as compared to the original versus generic. So the generics, there was a lot of debate on original and generic. So the bioavailability, the study by Sanjay Kalra and all, had shown that dapagliflozin, the original one, has a better A1C reduction as compared to, and has a lesser number of side effects. So the generic, so basically again the study on generic had shown better improvement from a postgraduate institute of studies. We come back to the same patient, that means on adding dapagliflozin, there was a significant improvement in the A1C and significant improvement in the proteinuria. So this agent, when added to the patients when you have microalbuminuria and preventing decline, so this is agent SGLT2. So what is the progress which is going on? You have number of agents which are over the horizon. How many one see the market? So basically, if you go back to the pathophysiology, you have the matrix deposition. There's a thromboxane antagonist, the agents which are going to work on the hemodynamics, that is mineralocorticoid antagonists and phosphodiesterase inhibitors. The agents which are going to work on kidney cell depletion, that is ASPK inhibitors. The agents are going to reduce the oxidative stress. Agents working on immunity, agents working on fibroblasts. So these number of agents would be seeing how many of them will see the light of the day. Possibly the future will only tell. So I will summarize that chronic kidney disease is a very prevalent and very underdiagnosed, and you require to, and early diagnosis and intervention, you require one, estimation of eGFR, which most of the labs have started doing now. You have to make sure that at least once or twice in a year you get urine microalbumin and urine albumin creatinine ratio. Guidelines do recommend now that early use of SGLT2 inhibitors to prevent the progression of the kidney disease. Dapagliflozin and along with SGLT2 inhibitors have shown beneficial effect in CKD patient. The evidence towards the original as compared to the generics is certainly there, and thank you for patient listening, and thank you for giving this opportunity to be here.
Thank you, Dr. Abe. May I invite you on the chair? It was with an army precision that he delivered the lecture. It was a wonderful hearing, and he brought out many and all the aspects about the CKD management in the early phase, if we can revert. Now, since we are already short of time, with the permission of the organizers, one question each for both the speakers who have done so well.
So I have a question for Dr.
Please, so let it be speaker.
No, so that's wrong. With a woman around, no man can speak, and I see a lot of men in the audience. My question is, how many of you have used finerenone, the new non-steroidal MRA? Yeah, Dr. Goel. So are we using it with SGLT2 for CKD, or along with SGLT2? So that is what I was going to ask you, that finerenone, how often do you use?
See, finerenone is recently available. It goes by the trade name Kirindia, and it costs almost 1164 rupees. So when you use it in patients when you already used SGLT2 inhibitors, and when they are moving from stage 3A, 3B to 4. So this is the time you would like to add finerenone earlier, But what happens is you have to add, one, the blood pressure reduction is quite great, and secondly, hyperkalemia is the second side effect. It's a drug I think you can add very much earlier along with SGLT2 inhibitors, and you have two studies which the time was short, otherwise I would have covered. Fidelity study which shows a very great effect of Insulin.
My one last question, if there is no question from the house. When does the nephrologist takes over from the endocrinologist?
See, one nephrologist should be involved right from the very beginning when your patient goes into 3A or 3B. There's no harm in advising the nephrologist because two physicians looking at a patient, certainly when the patient comes with high macroalbuminuria with decreased eGFR, I certainly involve the nephrologist. So basically, they look at the patient as far as the antihypertensive in a different way and possibly adding. So when the patient gets into stage 4, this is the time when you state the vital markers and try and look at the vascular excess. Possibly 3A and 3B is the stage when you must involve the nephrologist also.
I'll just give my last comments for the physicians here that in a patient of CKD, your job is to give the hepatitis B vaccine, number one, and you should read about it, double dose to be given, because once the patient is with the nephrologist and on dialysis, risk of developing hepatitis B from dialysis machine. So that is my last comment, and anemia correction and vitamin D is important.
So that goes in the management of CKD undoubtedly. Thank you speakers and thank you audience. Thank you for.
Thank you so much, ma'am and sir, for the comprehensive session and enriching our understanding. I would now request, that's what, Dr. Harpreet Singh, please. Dr. Abhay Ahluwalia, to please present the memento as a token of appreciation to Dr. Meena Chhabra and Dr. Abhay Ahluwalia. My apologies. Platinum, ma'am.
That's okay.
Yes.
Are they getting bottles?
Yes, sir. Yes. Yes, sir. Yes. Thank you.
Yes, I am calling, sir. He's on the phone. Just a minute, sir. I would now like to call upon Dr. Rajiv Chavda to please present the memento as a token of appreciation to Dr. Harpreet Singh. Thank you so much, sir.
Childhood friends.
Wonderful. Thank you so much, sir. Thank you. The next symposium is addressed by none other than the man himself, who needs no introduction. And to chair the symposium and on non-sugar sweeteners, I would like to call upon stage Dr. Ravi Mohan, MD Medicine, practicing physician, Rohtak, and Dr. V.K. Goel, Head of Department Medicine, Mata Chandan Devi Hospital, New Delhi. Stage is on your side. Thank you.
Dr. Chawla doesn't need any introduction. A sweet person will be talking about artificial sweeteners. Okay.
Thank you, Ravi.
Chawla.
Thank you. So, this is the last session in this hall, and what I am going to do is to clear certain myths which are around non-nutritive sweeteners. I know of late there was a controversy since the guidance by WHO, I think somewhere in March it came most likely, and there has been a lot of hue and cry on non-nutritive sweeteners since then. So flow of my session will be first to tell you what are sugars, are they major source of calorie intake? Yes. And what are NNS, a sugar-free alternative to cut down these added sugars? What are the myths around NNS? What are the health outcomes of NNS? And what is the current status, whether our own DCGI and other authorities have cleared it or no? So sugars are a major source of calorie intake. We know that whenever we need to cut down on dietary sugars, we tend to recommend NSS, and normally we tend to, unfortunately, we as an Indian, we tend to consume huge amount of free sugars, which are going to lead on to higher prevalence of type 2 diabetes, obesity and CVD also. And that is why probably there is a need to cut down on total calories, that too primarily which are coming from the sugar sources. Well, WHO recommendation for intake of added sugars is that adults and children should reduce their daily intake free sugars at least to less than 10% of the total calorie intake. Unfortunately, it does not happen. In fact, further reduction, if you can ensure anything close to 5 to 6%, if you can make sure that you will get 5 to 6% calories only coming from sugar source, probably it can make huge difference in terms of obesity reduction and also in terms of reduction of CVD. Well, science behind sugars is that sugars are calorie sweet tasting carbohydrates that occur widely in nature, including fruits, vegetables, honey, milk. Most of our oral intake, they do have some component of carbohydrates. The types of sugars are mono, di and oligosaccharides. Monosaccharides are which are monomer, which are directly absorbed in the form of sugars. Typical is glucose, fructose and galactose. And disaccharides are when there are two molecules monosaccharide linked together, and these are the primary source in human diet like sucrose and lactose and maltose. And oligosaccharides are when you have couple of these clubbed together, up to 3 to 9 monomers together, it becomes oligosaccharide. And common source is fructose rich corn syrup, which on WhatsApp you keep learning every day that these are the good source, and these could be consumed in any amount, any portion size or amount. So dietary sugars are our major source of calorie intake. So these could be from the natural sources. I have already told you the natural sources, and these could be as artificial sweeteners which are into the packaged foods as sweeteners, or maybe from concentrated fruits or vegetable juices or beverages. So unfortunately, as I said, there is a very high intake of added sugar in India. If you look back almost 10 years or 15 years ago, that time oral sugar content was, because we were not consuming too many beverages and we were not sort of consuming packed food that time. Of course, the now trend is that we tend to consume lot of packed foods which have very high content of sugar. So normally it says that average sugar consumption ideally should not be anything close to 20 to 23 gram per kilogram per year. But unfortunately, we in India, we tend to consume almost 25 kilogram per person per year. That is the total consumption which happens in an average person. There are certain persons who have sweet tooth, they consume too much of sugar. Certain persons may consume less of that. But on an average, we tend to consume 25 kg per person per year. And unfortunately, there has been an increasing trend of consuming more and more sugar over last 10 years. Earlier, we were consuming something close to 55, and this has gone up by almost 150%. So there is almost 1.5 time increase in our sugar intakes, what has happened over last 10 years. The calorie intake due to added sugars from common Indian foods, I'll not go into the detailed list. I'm not a diet consultant by profession, but definitely one thing we know that sucrose, glucose or fructose, they tend to give you around 4 kilocalories per gram of amount which you are going to consume. Sources of added sugars in Indian diet could be either in the form of sugars, honey, brown sugar, jaggery, etc. Bakery products are especially rich in carbs, especially these are refined carbs which may do little more harm, and traditional sweets, they are all very, very rich in carbs and calories. So added sugar actually should be viewed as a sweet poison. These are very sweet, give you excellent taste, but these are the one which are going to increase the overall prevalence of metabolic syndrome, weight gain, obesity, hypertension, maybe other cardiovascular diseases. These are moment there is a little weight gain, there is going to be a sudden increase in insulin resistance, which may worsen your predisposition to diabetes if you are say pre-diabetic simply. Dental caries is also on very, very high side. Then gout and pancreatic cancer and kidney diseases have been linked to higher intake of glucose. Nepheld in the morning I talk about has a very, very strong link. What we say, if it is a bad diet, especially if it is very, very rich in fructose or maybe glucose, and of course gut dysbiosis and metabolic imbalances. So NNS, which is non-nutritive sugars or low calorie, certain are totally without calorie, 0 calorie, certain are very, very low calorie, so it is low calorie sweeteners, provide a very safe option for reducing sugar intake. Having said that we tend to consume very high content of sugar, that too especially through these packed foods or maybe our sweets, which are very, very common in our community. So if we need to cut down on that, their NNS plays a very, very important role as an alternative to cut down added sugars. And these NNS could be, if you view upon their journey over last almost 120 years or 140 years more precisely, saccharin came as early as 1879, almost 140 years. Stevia is available since 931. Cyclamate we are not usually using. Aspartame has been used since 1965. Asulfame K is again since 1967. Sucralose is there for almost 50 years now, and neotame we are not really using much. So the characteristics of various NNS are, saccharin has the highest amount of sweetness as compared to the sucrose. It is probably as high as 600 or 500 times sweeter than the routine sugar which we use, which is sucrose. Good thing is it has 0 calories and acceptable daily intake, ADI, where it is absolutely safe. You can say if you consume this much, 5 milligram per kg body weight, you can very, very safely use. It is hardly metabolized. Actually, saccharin came in controversy almost 100 years ago because of little higher prevalence that was noted in rodents, not in human patient, for carcinogenesis. Stevia, I told you, is again available for good 50 years. Sweetness is close to 250 to 300 times. Again, 4 milligram of cereal equivalent can be used on daily basis per kg per day, so which is absolutely safe. Then aspartame, again it is 160 to 220 times sweeter. It has 4 calories, very minimal calories, and acceptable dose or ADI is 40 milligram per kg daily basis. It is metabolized to its constant amino acids and methanol, by and large it is safe. Sucralose has been in good practice. Most of the sweets actually tend to have, which are branded or sold as sugar free, are having sucralose, which is again 400 to 800 times sweeter than sucrose, and again ADI is 5 milligram per kg per day, so it is minimally metabolized, so not much of side effects. So when you are using NNS as a sweetener in an attempt to reduce oral sugar intake, so there are going to be benefits in terms of course there is not going to be any effect directly on glycemia. Only thing is your sugar intake is going to go down, so maybe you might have a better glycemic control. It definitely helps in weight reduction and maintaining weight. These sweeteners have, in the long run, that is how this controversy came. I'll be addressing that by WHO, that in the long run it has been seen that if you are chronically using it, there happens to be some amount of weight gain, but prevention of dental caries is very well established, because if you are consuming this, comparing versus oral sugar, the incidence of dental caries is very, very less. Now I'll be taking certain myths and what are actually the facts, why there is a controversy on these NNS. So acceptable daily intake is, I told you, it is defined as an estimated amount of a food additive which is expressed per kilogram of body weight, and it can be ingested daily over a lifetime. The basic principle of all NNS is that whatsoever amount, as I said, 4 milligram and 40 milligram, these are already 100 times lesser than the toxic doses. So toxicological studies are done first on rodents and then maybe human models, and subsequently on human trials it has been seen if the safe dose is say 400 milligram, they will allow you only 4 milligram per kg per day. So it is already 100 times lesser. This is how you calculate ADI. When there is highest dietary level of NS, which has no adverse side effects. So one is ADI, which is the minimal which will be recommended, and NOAELIS, which is the highest dose, but it is still found to be absolutely safe. And we divide this with a safety factor by 100 again to be doubly sure that whatever amount we are recommending is going to be absolutely safe. So this comes out to be very, very low amount, and especially in our population, we are not taking 10 or 20 glasses of coffees or milk added with sweetener. We tend to consume maybe 2 or 3 coffees or 2 or 3 cups of tea, or maybe once a milk, and we don't consume too much of beverages in our population. We don't tend to consume on daily basis those packed foods which are definitely having higher amount of these NNS. So for stevia, it is 0 to 4 milligram. That means toxic dose will be 400 milligram. They are allowing only 4 milligram per kg per day. And for aspartame, it is 40, because highest dose which has been used where some amount of toxicity was seen was 4000 milligram in the trials. And so is sucralose, 5 milligram per kg per day basis. So now I must clear certain myths. NNS is associated with risk of developing cancer. This is how saccharin came into controversy 100 years ago. 2014 US FDA, which is one of the most stringent agency before it clears any drug or any food additives or anything, clearly said, and subsequently it was endorsed by American Cancer Society in 2020, that all NNS appear to be safe when consumed in moderation. So moderation is that allowed dose, that too also we are not consuming in our ethnicity on very high doses. 2006 NCA examined human data from these diets and health study of over 500,000 people, and it was found that increasing consumption of aspartame containing beverages was not associated with development of lymphoma, leukemia or brain cancer. So 2020 American College of Oncology cleared that these are going to be absolutely safe. Systematic evaluation and integration of mechanistic data into the totality of evidence reported that sucralose is unlikely to be carcinogenic in humans at all. And these are the evidences. I will not be able to go into the details of these studies. These are all systematic evaluation and integration of mechanistic data which are available on steviol glycosides, on sucralose, on aspartame, and all you see that in conclusion have written that there is lack of any genotoxic or any carcinogenic activity, whether with stevia or with sucralose. So these are found to be absolutely safe. Another myth is that NNS consumption will alter gut microbiota. There has been recent one study, I think, that got just published by Dr. Mohan Center, also very clear that even if you are consuming these on regular basis, there is not going to be any alteration of the gut microbiota which may do any harm. Well, this is another evidence which says that human studies are limited to providing adequate evidence that NNS influence gut health, but these are not randomized controlled trial. Evidence from animal models have demonstrated that it could alter gut microbiota, but human studies have not verified that. A recent human study reported that daily intake of pure sucralose or aspartame in doses reflective of typically high consumption has minimal effect on gut microbiota. But I think Dr. Mohan's data, they have used almost in 450 patients, and they clearly demonstrated that there was no change in gut microbiota at all. So that is a very core evidence which has recently come somewhere in June. So evidence on effects of NNS on gut microbiota, you could see that daily repeated intake of pure aspartame or sucralose has minimal effect on composition of gut microbiota or production of short chain fatty acids, which are blamed for development of Neufeld and Nash, what I said in the morning. So there is hardly any change, no change in negative bacteria, nor there is any change in a positive gut microbiota. Another myth is that these sweeteners are associated with chronic kidney disease. So again, the fact is that National Kidney Foundation, which is a true guidance planning and emergencies, it's a guide for people with chronic kidney disease, recommends that even adding an artificial sweetener as a part of emergency diet plan in those patients with CKD is found to be absolutely safe. And here is a meta-analysis of RCTs and observational studies, and this again concluded that sugar sweetened beverages increase the risk of CKD by 1.58 fold, but this was not p-value wise significant, and no significant association between these sweeteners and CKD actually could be established. So let's see other health outcomes of NNS in terms of weight management. That is why we tend to recommend it to our diabetic patient or those who are pre-diabetic or those who are already obese. Actually, these promote weight gain by increasing appetite and hunger. These are observational studies. Based on these observational studies, actually WHO has given that current guidance. But in the randomized control trial, which are meticulously designed trial, they have said it supports weight loss and maintenance by reducing intake of sugar containing foods. So I think this issue, although still needs to be sorted out by having more prospective, larger RCTs to say whether being on an NS will increase weight. Of course, our clinical sense says that if we can reduce oral sugar intake and replace it with NNS, there is no reason that there is going to be any amount of weight gain. And these are RCTs on weight gain. You could see that 12 weeks data on stevia, there was hardly any increase in weight gain. Actually, there was a decrease in energy intake in the stevia group, and a linear regression model showed that positive association between weight loss and aspartame was actually seen. Then, of course, because someone who is consuming large or significant amount of sugar intake, which is going to increase fat storage, which will worsen insulin resistance, which will further increase lipogenesis and might increase Nepheld. In the morning you heard Dr. Wangnu talking about ectopic fat going into the pancreas, into the heart, into the kidneys, and I talk about ectopic fat going into the liver. All these things probably will further worsen beta cell and will lead on to development of type 2 diabetes. So meta-analysis of RCT said that use of NNS is associated with no increase in fasting and postprandial or HbA1c. Actually, these patients might be at a better end if they already have insulin resistance, because the moment you reduce oral glucose intake or sugar intake, there is going to be reduction in insulin resistance. So these trials, again study 1, 2 and 3 on stevia versus sucralose, aspartame versus sucrose and sucralose versus placebo, said that there is no effect on blood glucose, HbA1c, insulin levels or lipid levels either with stevia or with aspartame or with sucralose, and these have been found to be absolutely safe. Here is a meta-analysis of RCTs which suggested that blood glucose levels gradually declined over time, which makes sense when we are using NNS. Say if I am taking 15 gram or 20 gram daily sugar and I can cut down on that, there is no reason that sugars will go up. There is a reason that there should be some amount of weight reduction, and there is going to be reduction in insulin resistance also. Another important aspect is in dental health, because oral bacteria metabolize sugars to acids that immediately demineralizes the enamel and dentine. So this is a very important thing which leads on to dental caries. So if you are, instead of being on oral sugar on NNS, these are not going to be metabolized to acids by oral microorganisms. So there is going to be a significant reduction in prevalence of dental caries in these patients. So it could be actually an advantage. Let's see the current status of their approval. Saccharin is already approved in 100 countries. Stevia again in 50 countries. Cyclamate is not very popular with us. Aspartame we have been using. Sucralose is already cleared in 80 countries. And this is what is the status of Indian regulatory state organization, or the, you may say, licensing authorities. FFSAI, which talks about NNS and its approval, that stevia is allowed as a non-calorie sweetener, so is aspartame, which is allowed as a non-calorie sweetener, so is sucralose. So all these are already approved by Indian agencies and licensing authorities. US FDA also, its statement as early as 1981 that aspartame could be used as a tabletop sweetener. Subsequently 1996 FDA said it could be used even as a general purpose sweetener, irrespective whether you are diabetic or non-diabetic. So is sucralose, which is approved by US FDA as a general purpose sweetener that can be found in variety of foods, including baked foods and beverages. So the safety you can imagine is to that extent, irrespective whether you're diabetic or a non-diabetic, obese or non-diabetic or non-obese, these could be simply used as general purpose sweetener also instead of adding direct sugar, and so is stevia, which is found to be absolutely safe. This is European Foods Safety Authority again talking about aspartame. It is safety was of no concern at all. Same way stevia has been cleared. It is not going to lead on to any carcinogenic. Sucralose consumption of foods, drinks containing sucralose instead of sugar again may maintain tooth mineralization, may decrease actually dental caries, and so is ADA and American Diabetes Association and American Heart Association recommendation that use of NNS has the potential to reduce overall calorie intake, carbohydrate intake will go down, and these could be simply substituted by non-sweeteners, non-calorie sweeteners, and these might help to reduce the increase in blood glucose level associated with high intake of direct sugar. So if someone is consuming large amount of sugars, they cannot take a cup of tea or coffee or milk or say buttermilk without sugar, and you just cut down on those 3 to 4 teaspoons of sugar by NS. I think you do great justice to your prescription, and when used judiciously, it is not that we tell that anyone may use it and any number of times you may use it. If you are going to use it judiciously, probably you will cut down on added sugar and energy intake, and in the long run it may be of an advantageous. This is what I was talking about. WHO advises not to use non-sugar sweeteners for weight control. Try to go through this statement. I've read this entire document because I made a presentation in FCSCI about 3 months ago in Chamber of Commerce also, and I made this presentation against this WHO recommendation, that it is only that we are not saying that this should be used as a weight control measure. Only thing is you are going to cut down on calories by 20 grams or 25 grams. So in the long run, it has been seen that until unless you comply with other diets, until unless you comply with exercise, it is not going to make huge difference in the weight. So we are not using it for weight reduction. We are just using it as a sweetener, as an alternative to cut down on oral glucose. So various aspects of this report are that randomized clinical trial have shown that there could be small reduction in body weight initially, but in the long run it said that these patients, they tend to gain weight. But I think a prospective cohort study suggests that NSS intake is associated with increased body weight, increased risk of type 2 diabetes. But again in this study, the evidence, anything which is published should have an evidence 1A. Evidence for this study was very, very low to say that that is a concluding remark. So there are conflicting results between RCTs versus cohort case control studies. We probably need to have more randomized control trial, prospective trial with large cohort to say whether in the long run there will be a weight gain on NSS, because it doesn't make any sense that on NNS you will have weight gain at all. It may not lead on to significant weight reduction. In the long run you may be almost equal what someone is taking and not taking. So short-term RCTs have shown that those consuming NSS had a reduction in body weight. Those consuming NSS also exhibited a significant reduction in energy intake, which makes sense. Prospective cohort study suggests that possibility of long-term harm in the form of increased obesity, type 2 and cardiovascular disease and mortality could be there. So we have to be very, very pharmacovigilant. I'm not saying that you use it in prescription left and right for everyone. Don't use it for weight reduction alone until unless patient is going to comply with diet and exercise and the drug therapy if recommended, then probably these are going to be absolutely safe. So in India, we tend to consume almost 50% higher glucose, more so white sugar as compared to Western population, and there has been a significant increase, a trend over last 20 years to have more and more of sweeteners and beverages. If you tend to consume too much sugars from packed foods and all that, obviously that will do more harm. So this could lead on to increased incidence of obesity, cardiometabolic diseases, maybe higher prevalence of diabetes, hypertension and CVDs. Use of NNS is an effective strategy. It has to be part of your overall management. It is effective in weight control, diabetes management and prevention of dental caries. That is very, very important, and its consumption is found to be absolutely safe. This was a seminar, Dr. Mohan was also part of that, and there was a very long discussion over 3 hours, and again we tend to sort of counter that WHO statement which came, and a lot of that came also in press, that we are not recommending this as a weight reduction strategy, but to help our patients out, those who have type 2 diabetes, obesity or maybe higher CVD or insulin resistance. There it could be a wonderful alternative to oral sugars. Thank you very much for your patience listening, and if you have any questions, I'll be more than happy to.
Thank you.
Yes.
Thank you, Dr. Chawla, for an excellent insight into the use of NNS. You said the sugars are bad, and then, but we have an alternative in NNS, and then you have busted few myths. So any questions regarding that?
Yes.
Dr. Chawla would love to answer that.
So stevia is considered to be safe, right? Like a leaf. Right? So what if we give stevia to patients with CKD? Is it safe for them and to NAFLD?
It is absolutely safe.
For liver patients
if you
also?
read the entire insert of stevia, which is sugar-free green, stevia, they write it as something like what we use tulsi, it's a Japanese tulsi. Right. So this is what we tell our patient. It is like in our tea we must pull tulsi and adrak and all that. So it is Japanese tulsi product, or derived from Japanese tulsi leaves, and it has been found to be safe even in pregnancy, even in children. So you can use it, but only thing is, let's not say that you use it everywhere. That is not to promote that you use say these non-diabetic or something like sweets or cold drinks and all that. So we don't need to promote it that way, but we need to have a very balanced view that we can use it as non-nutritive sweeteners as an alternative to oral sugar.
And so other sweeteners that which
Sucralose is safe.
CKD
Sucralose is safe. Aspartame is safe. Saccharin has been, except one case report which killed saccharin almost 100 years ago, not even one incidence of carcinogenesis has been reported with saccharin. Yes, sir. Type of?
And mixing of foods, does it affect the efficacy of this drug, or does it make it more toxic? Supposing we are mixing with the different foods, non-veg, all fried and everything, and all spices, sour and everything. So with the mixing of the change of pH, use with all the foods, mixing with the foods and type of cooking, supposing deep fried.
Type of cooking, I think that is important. She's a nutritionist, she can tell you. I think the way you cook food, that is going to make, most of these sweeteners are not to be cooked. Not to be cooked. These are to be sprinkled toward the end before it is served, because that may totally denature it and may make it little more toxic. No, it is not to be, yeah. Yeah, it is not to be
even in
cooked
tea,
like,
even in tea, it should be put in afterwards. Not
after,
that
yeah,
put it
that
in.
is what I said. Before you serve, like maybe in kheer or something you want to sprinkle, you may use it. It is not to be cooked like we cook sugar and make kheer or dalia or something like that.
I think it's a very pertinent point that Doctor has raised. It's very pertinent point. Take the mic, sir.
Lot of spices, fried. We are taking the food, and
Agree.
after that we take the sweets.
Okay.
And if even if it is put afterwards, does it going to affect the?
Maybe.
Dr. Rajiv.
Yes, sir.
Thank you for a wonderful lecture. I'm a cardiologist, but still here to hear you. My first query is that in common sense, in the hotel, I just had a coffee. There was a white sugar, there was a brown sugar, and there's a good sugar. What is it known as bura? Did you spent about 5 minutes on the sugars? So is there any difference between these three?
See, glycemic index is different. But what you need to see is the glycemic load ultimately. If you are going an equivalent amount, which will finally lead on to an equal excursion, there is no difference.
I just want to know, as far as calories...
Obviously, glucose is the sweetest.
No, not glucose.
Then is
regular sugar,
sucrose, your regular sugar. Then could be brown sugar. Then could be your bura and maybe shakkar. But
Shakkar,
all
everybody
these.
has used that.
So one thing is, it depends on how much amount you are going to take.
1 spoon of 3 are available. Which one
you will like to answer that? Yeah, that is what I am saying.
So I said day-to-day practical query.
It is 70% for white sugar, glucose. It is 70%.
Not glucose. White sugar is not glucose always.
Pure glucose, I am saying.
Sir, in our food science book, it says sugar is sugar,
Sugar,
is sugar
yeah.
is sugar. So whatever
Glycemic load is almost the same.
The calories will be the same, but the glycemic index will be different.
Yeah,
it
that
will
is
be
what I said.
The excursion
What
is your
is
recommendation.
excursion is different.
What is your recommendation?
You should not use. I tell my patient not to use. I tell them sugars are sugars.
See, I
Anything I tell my patient, anything जो आपकी जीभ के ऊपर मीठी है उस वो sugar ही है.
Secondly, from a cardiologist perspective, like we have got Lona.
Lona is low
Which
sodium.
looks like a normal,
I got
normal
to find
common salt.
that shakkar could be Lona in that way.
Do
you
we
want to say.
have do we have any product available in the market?
I'm not sure. There is.
Which should look like a sugar, but is not that sweet.
But
That's
take-
my question.
Take stevia, no sir.
Sir, dates.
Stevia is like that only.
Sir, dates, raisins, and you should ask your
Ma'am,
patients
they're too expensive.
for a layman rather than telling them that okay, if we compare white sugar, brown sugar, jaggery, and all that stuff, because after a certain point they would not really be able to understand and bifurcate between all those things, saying that okay, this is good and this is bad. If we bring it to a layman, to a patient, we can simply say that take out your sugars from as natural sources as possible.
Yeah.
Okay, thank you.
Aim
Madam, there is
is
a,
to-
sir,
aim
there
is
is
to-
Dr. Chawla.
Yeah.
Is there a difference between the normal sugar and the coconut sugar or a khajur sugar or a honey? Is there any? People come and ask coconut sugar or all sugars are sugars.
All sugars are sugars.
And the best is a sweet smile. There is the most sweet. So stevia is the call of the day.
So thanks a lot.
Thank you so much.
I think but I'll request all of you not to leave. Please join in the other hall. We have two very important, Dr. Inash Sheltouts and Dr. Das and Dr. Bansi's lecture is going on. Please join us there. Thank you very much.
Thank you. Thank you. Okay. Thank you.